All right, good morning, everyone. Welcome to our final presentations for the class of 2018. It has been a fabulous year. This has been a great group, a really wonderful energy amongst everyone, a lot of collaboration, great friendships, and all of us so appreciate all the hard work and the energy and enthusiasm and interest all of you take in our work, and all the joy that you bring to work every day. None of these projects could go forward without your involvement. And to me, the highlight of the year are the intern presentations. We sort of see how people start the year as undifferentiated post-baccalaureate students into people who really have, who are self-possessed, have expertise in their particular area, have really matured into expert presenters, and I think you should all be incredibly proud of yourselves for what you've accomplished over the year or two that you've been here. And no matter what you decide to do in the future, I know this year will have served you well, and we know that all of you will be successful. We have no doubt about that. We all look forward to learning about what your particular insight is, and I think this is for all the new interns who are here. This will give you a snapshot of not everything that's going on in the program, but most everything that's going on in the program. And so this is your first jump into the deep end of the pool, but don't worry, we know that you all know how to swim. And if you need some help, we're there to encourage you along. So with that, we're going to start with our presentations. Don't forget, all you interns presenting, start with your most important takeaway lesson for the year, and a little bit about how your work applies to the other work that's going on in the BCC. And we look forward to hearing all of you. So we're going to start with Fiona at the Young Women with Breast Cancer Study, right?
So from my role as an iSpy coordinator and being a member of the Patient Support Corps and the Firefly Project, and also being on the other side of it when my dad was diagnosed with prostate cancer this past year, I think I've really learned the importance of not reducing someone to their diagnosis or their medical record, and that it's really important to have conversations with people about what's meaningful to them, and trying to understand their stories in order to sort of meet them where they are, and really treat them holistically in a healthcare setting, and outside of a healthcare setting. As far as how my project in the Young Women's Registry is related to other work that's going on at the BCC, I think it's really directly applicable to iSpy. In fact, we're actually trying to migrate a lot of aspects of the program into the iSpy trial. It's also very closely aligned with the quality of life and the patient-reported outcomes initiative that Haley is going to be working on next year, and integrating that into a common platform of one source to sort of reduce patient burden for all those things. So today I'm going to be talking about young women with breast cancer at the Breast Care Center, and this is really just presenting our pilot data that we've been collecting so far. So what's the problem? Younger women with breast cancer often experience a lower quality of life after breast cancer compared to older women. This is for a number of problems related to systemic treatment side effects, treatment-related infertility, and psychological distress in relationships with spouses and young children. And also they generally have a more negative body image after surgery than older women. The prognosis also tends to be poorer in young women because the tumors tend to be associated with more aggressive features. A SEER reported that 20,000 women are diagnosed under the age of 45 with early stage breast cancer per year. About half of these women may desire future fertility, and almost all of those women receive some kind of treatment that might compromise future fertility. So we were interested in answering how these trends might apply at the breast care center. So to this end, Dr. Chen, I've been working closely with her to establish the UCSF Young Women's Registry along with Molly. We opened it in December 2017 for women under the age of 45 with early stage breast cancer. We're actually going to be expanding it to include women who have metastatic disease as well. The aims of this were to characterize the demographic, clinical, and pathological characteristics of young women who come through the breast care center, and also to prospectively identify sort of the unique qualitative issues that they face at diagnosis and onward. So today I'm really going to be focusing on this second aim. To meet this end, we developed a REDCap-E survey for eligible registry participants who were within 6 months of their diagnosis with early stage breast cancer. The IRB just approved it in June 2018, so we have some of the pilot data from the baseline survey. This survey was really aimed at prospectively assessing how attitudes about fertility and future childbearing might change over time, why they're changing, what risk women are willing to assume to get pregnant, and also some other quality of life domains like sexual well-being, financial toxicity, and satisfaction with social roles. I'm going to be looking more at 1 through 4 today. So we had 32 women who consented for the registry so far. 11 were not eligible to fill out the survey, so we had 21 women eligible to complete the survey. Of those 21, 15 completed the survey, so we had around a 71% completion rate. The time from diagnosis to survey completion, the median was 5 months. So who were the women who filled out the survey? So their average age was 36.9 years. Majority were white and majority were non-Hispanic and Latina. Most of the women were married or in a committed relationship. The average age of menarche was 11.8 years, which is slightly below the national average of around 12.4 years. The age of first delivery was 30 years, which is also slightly above the national average, and both of these things are risk factors for breast cancer. Something got messed up with my slides, so the actual percentages and category names aren't on there. Well, the big lighter green category are patients who receive both chemotherapy and hormone therapy. The blue category is women who received chemotherapy alone, and the yellow category is women who received hormone therapy alone. So around 90% of women received chemotherapy and around 2/3 received hormone therapy with or without chemotherapy. So women expressed concern with a number of relationships outside of their diagnosis, but I'm looking at mostly the ability to have future children. So 8 women said that they were interested in having biological children in the future, and 7 said they were not. The women who were not interested listed these reasons as why they were not interested. So the majority of women felt that their family was complete. And this makes sense if you look at the average age of these women. Women who didn't want future children had an average age of around 39, while women who did want future children were slightly younger on average. How do the demographics compare between women who do and do not want future children? So, sorry, I'm not sure why these numbers aren't working. So 7 women had no children, and these women all fell into the category of wanting future children. All of the women who did not want future children had at least 1 child. Current relationship status. So most women who didn't want future children were either married or in a committed relationship, but that's not all true. For tumor subtype, there was not really any real trend. Women who did have higher risk subtypes like triple negative and HER2 positive cancer still did want to have children in the future. This was the distribution of clinical stage amongst the women, and they're also, they're in the more advanced stages, women still wanted to have children half of the time, approximately. So characterizing the actual attitudes of women who want to have future children. So we asked them a number of questions on a 5-point Likert scale from strongly agree to strongly disagree. The women who answered this were the 8 women who said that they would like to have children in the future. So of those women, 53%, you can't see the values, but those 2 blue strongly agree and agree categories add up to 53%. So they felt that it was important to have biological children. About a third said they would consider adoption, and also about a third said they would consider use of a surrogate pregnancy. So if having biological children is so important to these young women, how much risk are women willing to assume to get pregnant? So we asked them a couple hypothetical questions. So in this question, we asked women if your risk of recurrence were represented by one of the risk intervals on the left, would you still want to get pregnant in the future? So you see sort of the trend you might expect that at a low risk of recurrence, everyone wants to get pregnant. And then as you go up in risk, fewer and fewer women would like to get pregnant. But there were still 2 women who, even in the highest risk categories, still wanted to get pregnant in the future. We also asked them, so pregnancy has not been shown to actually increase the risk of breast cancer recurrence, but we set up a hypothetical situation in which it did. And we saw a similar trend where as risk goes up, the desire to have your own pregnancy goes down. We also presented them with the option to have to use surrogate pregnancy. And so that was sort of a trade-off that a lot of women were making, but there were still some women who said that they would rather not get pregnant at all rather than use a surrogate. We also asked a similar question regarding stopping hormone therapy early in order to get pregnant, and we saw almost an identical trend. So then we asked women who were interested in having future biological children about whether they underwent egg or embryo harvesting. 75% of them did. 5 women froze eggs or embryos, and 1 woman froze ovarian tissue. The women who did not harvest cited these issues, so the most common was they were too overwhelmed to think about it, and financial reasons. So we also asked women if they felt that they had control over their reproductive future. Around 23% thought they did, and 31% felt that they didn't. So how is this different between women who underwent fertility preservation and those who did not? So amongst the women who underwent fertility preservation, around 50% felt that they did have control over the reproductive feature, while both of the women who did not undergo egg or embryo harvesting, they did not feel like they had control over their reproductive future. This might be driven by the trends we see in these questions, which is that women who underwent fertility preservation sort of unanimously agree that they're keeping an option open for themselves, and that it reduces their anxiety about being able to have children in the future. We also asked them if they felt that they made the right decision about freezing eggs or embryos, and unanimously the women who underwent egg and embryo harvesting felt that they had made the right decision. And in the group who did not harvest, 1 woman was neutral and 1 woman felt that she had made the wrong choice. And just to wrap things up, we asked them about how egg and embryo harvesting impacted their level of stress, and it was a write-in question where they could give us their explanation. And generally what we saw for the women who felt that it increased their level of stress or anxiety was that it was actually the processes and logistics of going through the egg and embryo harvesting that was causing that increase. And then for the women who said that it decreased the level of anxiety or stress, it was really about keeping that option to have their own children one day in the future, in sort of an uncertain world that they are in. So future directions, continue to collect data about psychological and psychosocial stress for young women to identify who is most at risk. And maybe we can tailor interventions one day to improve quality of life for these young women. We also want to make sure that this is poised to be integrated into the future OneSource platform to decrease patient burden. And we're also, as I mentioned, interested in looking at how this may fit into the I-SPY trial. So thank you.
Great job. I think it challenges our ideas as clinicians as what is considered a full life. When the clinicians are thinking about treatment at all costs, survival at all costs as the single endpoint, when most people actually think about what they consider a full life, that they want to be returned to a full life. And if they haven't had children, that full life presumably includes having children. Is that if they haven't had children, right? Or most people. Joe?
I mean, I don't know if you can go back to the slides showing the risk patients are willing to
It's
take.
amazing.
I think those are the most interesting slides. So a couple things. This didn't even go live until early June, so less than a month. And we gave it out to 20 patients and 15 of them have returned it. So the response rate is really high based on other surveys. This is actually, patients are really motivated to fill this out. 8 of the women who wanted to have children in the future, we look at these responses. It's incredible to me that 5 of the 8 said if their risk of having recurrence, if they knew it was going to be over 50%, they would still want to have a child.
And this was also phrased as an incurable recurrence, so a metastatic recurrence for these patients.
And that carries through in all of our hypothetical situations where you'll see actually a drop off around 25%.
Yeah.
Where you get the most significant drop off between patients who want to have a child, but at 25% risk, that's when they decide that it may not be worthwhile. And I think that is a really interesting data, just so we understand patients' risk profile and what is worthwhile to them.
Mm-hmm.
But regardless, more than half of these 8 said even if they knew they were going to have a metastatic, they would still want to pursue pregnancy.
And so I think that one of the, I'm sorry Jeff isn't here, but we'll make sure to tell him, but I think this is like when we started the whole patient support core, the whole decision services program way back when, it was really when Jeff was a graduate student and was doing some work with me. And I had offered this woman reconstruction, and the problem is she had this terrible complication. And she actually was then precluded from going on this cruise with her mother who was dying. And because I hadn't asked her what was important to her, I missed what really made a difference, and I screwed up. And that was actually when Jeff and I said, my God, people need to know what matters to people. That's what's wrong with guidelines. Guidelines are a bunch of physicians sitting around in a room deciding what patients want. That's actually not what you should be doing as physicians. And I hope that this generation of people will go out there and change the world. That's what we're trying to do. That's why this PRS portion of your training is so important. This is your chance to really listen without any filter to what patients want. And get in your mind that what we think is important, I mean, we actually serve our patients, and we have to serve what's important to them. And this gets to long-term hormonal therapy and people being told they can't take a break and can't have children. So I think this is just incredible data. And don't you?
And interesting, that's why we're expanding it to the metastatic patient, because we have biases too as providers.
That's right.
Historically, myself, when it's a metastatic patient, I don't find myself even talking about fertility. But we all, as providers, have at least a handful of patients in
That's
the
right.
metastatic setting who have gone on to have
Right.
children through surrogacy and so forth. And so I think it's super interesting to
Yeah.
survey the metastatic patients in the same way, because 2 out of quarter of these patients that knowing 100% that I'm going to send to parents, I still want a child.
Yeah, so again, it is what do people consider a full life? And what is it we're returning people to? And I think that's the exciting thing about I Spy 2. Plus, we're moving to trying to think about how to move into less toxicity and things that really actually matter most to patients. So very exciting. Fabulous work. All right, Helly, you are next.
Hi everyone, my name is Haley. One of the biggest takeaways from this year for me was learning that research is clinical care. This was drilled into me in a meeting that we had where Laura had everyone in the room go around and say, research is clinical care. But it was also driven home for me in the work that I did this year on OneSource, which I'll be talking about today. I learned that researchers care about the same kind of information that clinicians and healthcare providers do, and that every time we conduct research, we are advocating for our patients. And I learned that the idea that Laura champions of never accepting the status quo applies to both research and the clinical setting. So to me, a big takeaway from this year was learning that these are not separate entities, but really one and the same. I've had a huge privilege this year of working with several of the other interns on my OneSource project. I will be today talking about how we hope to streamline data capture for the I Spy trial. I also worked with Emma on the prospective DCIS study and how we can hopefully capture data and streamline data capture for that as well. In looking at how how the deployment of OneSource may change the clinic workflow, we thought about how we can improve Athena BCC questionnaires and how we can have more people filling those out. And in the future, and in this coming year, I'm going to be taking on some of Jenny's work on I Spy quality of life and thinking about how patient-reported outcomes can be integrated into our clinic workflows as well. So today I'm going to be talking about some of the impacts of OneSource in research and in the clinic. OneSource is an ambitious effort. It aims to reduce data entry for clinicians. It aims to reduce chart review for researchers. It aims to improve the way that we care about our patients. And it ties together, as I mentioned, several of Laura's other initiatives. We're currently in the launch or pilot phase, but we've done a lot of work in that phase in the past year that I want to talk about today, and there's some more work that needs to be still done, which I hope to take on now in my second year at the BCC. So to kind of get everyone up to speed on what some of OneSource's aims actually are, I want to give a little bit of background. So many of us have interfaced with EPIC or the EHR in some kind of way. Clinicians and healthcare providers, nurses, and clinic staff may have had to sift through clinic notes looking for information that they care about. And when they realized that what they were looking for was too hard to find, they've had to go out and recollect that same information, put it into new notes, which are no easier for the next person to find. Many of us as interns have spent several of our days here also combing through patient charts, looking for the information that we care about and putting it into separate databases so that we can analyze it. But the problem is that a lot of this data is, one, collected multiple times over and over again, and two, in unstructured format. So in paragraphs of free text rather than simply entering a number into a data field or checking off a checkbox. We talk a lot about precision medicine and how we hope to deliver personalized and customizable care to other people and our patients. But the way that the EHR is built and what its tools can do right now don't support that idea of precision medicine. Our databases are really just back-end systems which are trying to tap into that unstructured data in the EHR. And right now we can't really practice that precision medicine that we hope to practice. So our proposed solution is OneSource data platform, which hopes to capture structured data at point of care. And the way that we hope to do this is through OneSource checklists, which contain mission-critical data elements for diagnosis, treatment, and our outcomes. And we're hoping that OneSource can act as one validated source of truth, even if it's attached to many other source documents. Think of it like a pilot using a checklist before takeoff and before landing. And the idea that if that pilot had a co-pilot, that co-pilot would be building on the information of the first pilot rather than starting from scratch and putting information into a completely new system. The FDA is interested in the work that we're doing, and we have a collaboration with them. We're working right now on a proof of concept based on some of our commitments to the FDA, which include a gap analysis between the clinical data elements that we are collecting in the clinic and those that we are collecting because we care about research. Based on that, we're hoping to make some recommendations about the improvements we can make to the existing data standards. So in understanding this gap analysis between data elements that are collected in the clinic and those that we care about in research, we're honing in on the I-SPY trial. This is how data is currently captured for I-SPY. We have our site coordinators, which for the time being are Colby and Fiona, and they have been collecting information from Epic, going through those notes as I mentioned, and trying to pick out the information that they care about so that they can enter it into the electronic I-SPY case report forms. What we hope data capture will look like in the future is that Epic will be able to feed into our one-source system. Our checklist will be able to centralize this data and structure it and organize it in a way where it can go back to Epic, where it can also be used to automate filling out these I-SPY case report forms, and where it can also be used in other applications for registries, quality improvement, and sending tailored educational materials to our patients. So some of the work that we're hoping to do in order to accomplish this, and some of the work that we've done so far, is what I want to talk about next. So far, we've tried to look at the overlap between our one-source checklist and the nearly 400 data elements in the I-SPY case report forms. So that body of work I've already done in this past year. And the next body of work that we hope to do is looking at the overlap between Epic and the I-SPY case report forms so that we can better understand, one, how much information in Epic is in free text form, how much is in discrete form, and two, how then the checklist can provide structure and act as this engine for decision support tools in the future. So OneSource is not just a way that we're hoping to streamline data capture, but also a way that we're hoping to transform the way that we capture information in the clinic. We as a working group have defined the clinic redesign as a way to allow for a standards-based decision support system that centralizes and organizes trusted data for clinical care, operations management, performance assessment, and research, so that patients experience streamlined care delivered by empowered teams that are continuously learning and improving. Essentially, this is a tool that will hopefully allow OneSource to accomplish all of those big aims that I mentioned before. So a lot of the work that I've done this year is in understanding the current state of our clinic workflow and going through and talking to various clinic personnel about how they're engaging with Epic, what kinds of information they're collecting, entering into Epic, and looking at and using that is already in Epic. So based on that, I built a huge map of a patient flow through the clinic and all the people that they interface with and the processes that they experience. I included just a small slice of that here, the pre-appointment slice, which includes pieces like getting an appointment scheduled, getting registered in the clinic, gathering records, and things like that. One of the big takeaways from doing this work was realizing that if we, for the data that we're trying to collect and the way that we hope that OneSource will run, we can't really support that in the way that the clinic is currently flowing. So looking at, we wanted to look at what we hope this pre-appointment stage can look like and what we hope the future clinic workflow can be like. So ideally, a patient would call to schedule an appointment at the breast care center, and then they would fall into one of two buckets, either those with a confirmed cancer diagnosis or those without a cancer diagnosis. Those with a cancer diagnosis would receive a new cancer survey, and then a nurse navigator would call them and assemble their information into checklists. And then they would also decide what kind of appointment a patient requires and what kinds of records are needed, which then an admin will gather. And then during an appointment, a clinician will simply verify data rather than gathering it all over again and add structured information to the checklist as necessary during the appointment. Alternatively, if a patient comes in with no confirmed diagnosis, they'll receive an alternative survey, after which if they're experiencing breast pain or a lump, they'll go to the lump and bump clinic for an assessment with a nurse practitioner. Otherwise, if they come in with abnormal imaging, they'll come to our same-day assessment clinic so that they can go through further workup. So in the coming year, some of the work that I hope to accomplish are those next steps, as I mentioned, for streamlining I-SPY electronic data capture, looking at that overlap now between EPIC and those electronic case report forms, piloting some of this work that I just talked about, and this hopefully some of these changes that we've proposed for the clinic redesign. And finally, as I mentioned before, I'll be taking on some of Jenny's work with I-SPY quality of life, and we're trying to think of ways to be thoughtful about incorporating patient-reported outcomes into these clinic workflows as well. And these are just some of the mentors who have helped carry out this work. Thanks.
That's awesome. Doesn't that sound great? If we could just do all that. So coming soon, and note, Laura V. and the Athena interns, that the work now of organizing all the surveys is now part of the routine of the clinic and not the purview of a research coordinator. So the whole goal of this is to make it sustainable, is to make it actually part of care. And then the Athena interns can actually be analyzing data. And just think how much better it will be for those coordinators. Sadly, it's probably not going to be open operational to help everybody, but all right, any questions? Adam, you love it?
Great.
Okay, the sooner we can do it, the better. Laura V.
Okay, I do have one comment.
Yeah.
So which is the Athena efforts in the BCC clinic. So I realized that you, in your patient survey that you're mentioning here, you have not mentioned Athena.
No, wait, she's talking about
so maybe
it is the Athena
a good
survey.
point in your next steps for the person, if you're continuing it or somebody else, that currently sort of almost 50% of all patients that come into the breast care clinic do answer a standardized questionnaire. So I think that will be important to continue.
No, we're just saying that that becomes 100% and it's the routine and it is the Athena questionnaire. That's what we're talking about. Right?
Yes.
Yeah, so, I mean,
Here it is.
well, but that's what we mean. I mean, we're not talking about a new questionnaire, we're talking about the Athena questionnaire. Right, but part of the reason it's not routine is because it's not the responsibility of the clinic. And for the longest time, I've tried to, is Diana here? All right, she's gonna have to. Aheli, your next task is to go do this presentation for Diana and Janet, okay? And the idea is, we've now proven that that works, and they have to make sure it happens. And Adam and I are going to figure out how to make sure it gets integrated into the medical record. Okay, any other questions? Okay, awesome. Colby, you are up next.
Hey. So over the past 2 years, I have danced and choreographed in Dr. Esserman's musicals, 3 musicals. And I found myself in an 18th century Hamilton costume, twirling on a stage, looking out and seeing doctors in the audience who had only seen me in clinic and kind of wondering how I got there. But what I think I really grew to appreciate was that as much as we hear about it and talk about it, it is really important to stay true to your passions. And so, however unrelated they might seem to your everyday work, because they make you think differently, they draw you together, and they really allow you to have a lot of energy from a place where it isn't really possible from anywhere else. So I'm really appreciative and grateful of having that support in that area, and will be very thoughtful in keeping that present in my life as I move forward. So I guess how my work fits in with everyone else is I'm really focused on high-value care and evidence-based care, and this fits in with things like Calm, where it's generating the data in real time so we don't have these huge lags. We can actually deliver high-value care in real time. And then also things like Wisdom, really working on the alignment between patient preferences, provider preferences, payer preferences, to make sure we're just doing the best thing possible for patients. So my project was looking at the performance and value of a scan called the PET-CT. So currently, one of the most important components of care for women newly diagnosed with breast cancer is staging, because treatment recommendations and prognostication will be very different depending on stage 2 or 3 breast cancer versus stage 4 metastatic disease. So currently for stage 3 patients, the national NCCN guidelines is the use of chest, abdomen, pelvis, or CAP-CT, with a full body bone scan, which I'll refer to for this presentation as standard imaging. So the standard has really been called into question with the advent of newer technologies like the PET-CT, which was introduced into clinical practice in 2001. So the PET-CT, or positron emission tomography with a CT scan, combines both radioactive labeling of metabolic activity with anatomic imaging in one setting. And the reason PET-CT called the standard into question is because PET-CT offered a lot of value gains. It was less radiation, the scans were shorter, they were proven to be better at detecting certain metastases, and some computer models had predicted that it would be more cost-effective. However, this cost-effectiveness and this value isn't uniformly accepted. PET-CT are not endorsed in the guidelines, and we still have huge barriers to insurance coverage for covering these scans in this population. So we turn to I-SPY 2, where we have women with clinical high-risk stage 2-3 breast cancer coming in and starting to screen. One of the main eligibility criteria in I-SPY 2 is no distant evidence of metastatic disease, which can be done in one of several imaging modalities. In either case, we're looking for incidental findings on staging imaging. If there are none, stage 2-3 disease, the patients are eligible for I-SPY 2. If there are, it requires some type of workup to prove and assess this imaging as a real, true positive metastatic disease. If that happens to be the case, stage 4 disease, not eligible for the trial. In some cases, however, there are false positives and the patients are eligible for the trial. So it's in this I-SPY 2 screening design where we can really enter and start asking some of these value questions. For this study, we chose to look at 4 I-SPY sites across the United States. That was UCSF, the University of Minnesota, the University of Alabama at Birmingham, and Georgetown. In this study, at those 4 sites, 812 women screened from March 2010 to December 2017. Of those, we knew confirmed metastatic status for 799. Of those, we had complete staging workup and follow-up data for 564. And then of those, 529 did either the standard or PET-CT and were included in the primary analysis. So first, we really wanted to assess that these scans were doing what they were meant to do, detecting de novo metastatic disease in the trial population. When we looked at this, 5% of patients in the trial population presented with de novo metastatic disease. Of that 5%, about half were detected by standard and half by PET-CT. And we do think this is an underestimation of actual de novo metastatic disease for stage 2-3 clinical breast cancer, because the trial population does select for people who are less suspicious for metastatic disease upfront. So next, we hypothesized that because of the fuzziness in the guidelines and because of lack of uniformity, that there would be a lot of practice variation at the different sites, and this is exactly what we observed. So you'll notice here that the majority of patients at UCSF and UMin did PET-CT for staging. The majority of patients at UAB and Georgetown did standard for staging, and then there was some sprinkling of some others mixed in. So 30% of patients at UMin did chest X-ray as initial staging, and this was significantly different. We then wanted to focus on some of the value gains we were getting by using standard over PET-CT. So the first thing we focused on was the amount of false positives. And what we saw here was that 22% of women who did standard ended up with a false positive versus only 11% who did PET-CT, and this was significantly different. So women who did standard were twice as likely to have a false positive. And we wanted to really assess this from a patient value standpoint. So we know from patient focus groups and patient interviews that false positives are one of the most disastrous things that can occur because it's a time where you think you're living with metastatic disease. When we looked at the time for false positive resolution, it was 11 days for patients. So reducing false positives is extremely important from a value standpoint for patients. Next, we hypothesized that because of these false positives, there might be a delay to treatment start, and in fact, PET-CT scans accelerated treatment start on the order of magnitude of 6.8 days on average. And we thought at first that this might just be explained by institutional difference because, as you saw from the graph, most patients who did standard were from 2 sites compared to most patients who did PET-CT from the other 2 sites. But even in multivariate analysis, when we controlled for the institution, this result was significant. Next, we turned our focus to some economic evaluation to determine the cost between the 2 scans. And we conducted this from the payer perspective. So how much are insurance companies actually paying for these scans? And when we look at this using Medicare national averages from 2018 and combining the 4 sites, we saw that standard cost on average $1,100 versus $1,400 for PET-CT. Interestingly, the price really increased a lot due to false positive workup for standard versus PET-CT. We then wanted to do a cost effectiveness measure called the incremental cost effectiveness ratio, or an ICER, which measures the cost of an intervention for some desired outcome. In this setting, it was the cost of using PET-CT per percent patient who avoided a false positive. For this, it was $31 for that effect, which showed us that it was likely cost effective. Of note, 11% of patients who did false positive workup in the standard setting did PET-CTs anyway, so there's also some scan redundancy, which was pretty frustrating to see for patients. We know, however, that hospitals actually set the price of scans. So we wanted to consider what would happen at a site who actually had a policy where they set PET-CT baseline scans at a price lower than standard, which is actually the current policy at UCSF. And when we looked at this using actual Medicare reimbursements to UCSF, we saw that standard was actually more costly than PET-CT by about $200 on average. And the ICER, or the effect we wanted, was actually from causing a savings of $10 per percent patient who avoided a false positive. Even more striking was when we looked at this from a private payer perspective using Anthem Blue Cross reimbursements. What we saw here was that actually standard cost twice as much on average per patient, and there was a savings of $95 per percent patient who avoided a false positive. So how did this happen and how did this come to be? Well, a lot of this has to do with alignment of interest and how that's necessary for high-value care. So one of the things that happened and how we got into this mess was PET-CTs came out as a new technology, and they were set at a certain price and bought by hospitals at this price. Well, hospitals rightfully then turned to a perspective of cost recovery. They needed to recover the cost of these new technologies. So they turned around to insurance companies and charged them at high prices. Well, the insurance companies turned back to the hospital and said, well, you have a standard in place that's cheaper. These aren't going to get covered. And what we get are sad patients, hospitals that don't get reimbursements covered, and insurance companies that are feeding into this loop of lack of innovation and evidence-based high-value care. So what this study also has implications for is the rollout of technologies in the future and what hospitals and payers should consider moving forward. So if a new technology comes out and it's set at a certain price, hospitals should consider setting that at or below the cost of the standard to make it appealing for insurance companies to cover it, leading to happy patients, driving up the usage and evidence for these scans, and allowing us to deliver high-value care to patients. So in conclusion, PET-CT did a lot of great things for our trial population. It reduced false positives, it reduced costs of the false positives, both indirectly in terms of emotional toxicity and directly in terms of actual workup procedure costs and time to treatment. So in all, it added significant value to this population of patients. It also has implications for rollout of new technologies in the future and what we should consider when innovations are happening. So some future work we're submitting to San Antonio today with this data, and then hopefully we will have some more evidence to help support changes in hospital pricing strategies and insurance coverage policies. I just want to have a lot of people to thank for this, and yeah, thank you.
Well, that was fabulous. So this is, again, came out of our Sparking Innovation and Healthcare Value retreat that we did 2 years ago, and which we will repeat again next year. So everyone should be thinking about ideas for that retreat. So Colby, if if we present this to all the programs here, what advice could we maybe, or what project or proposed rollout of a PET CT system across I-SPY would you suggest? What would you tell each PI maybe to go to their hospital with for their pricing?
So I would probably tell each I-SPY site to look at what they currently charge for the standard package versus what they charge for the PET CT package, and say, set the PET CT at a price that's at or maybe even 5% lower than standard. Then this will make it more appealing for insurance companies to cover the cheaper scan, and then this will allow you to give it to more patients and not face so many denials.
So Gila or Brian, one of you is going to take that very project on and help us figure out whether we can get hospitals to change their prices, and we can write that up too. And because that's, and we're going to present this to Anthem Blue Cross next week. Yes.
I think you focused in your conclusion on the cost, and I think that's great. I mean, that's where it should go. But part of these ICERs and the qualities is also what is the effectiveness of this new screening, and you also showed that actually you can reduce a lot of secondary, tertiary screens. And so what is your recommendation there? Because that might even be equally important, depending on what. It's sort of interesting in the discussions whether sometimes the healthcare industry then starts to focus on cost, and they no longer actually focus on all these other important parts.
Mm-hmm.
That's what the answer is.
What should happen there?
Yeah, so I mean, I think there are kind of two costs we're talking about. There's the direct of the actual prices, which you kind of have to use with insurance companies, but then there's the indirect. So I think it would be maybe worth following the quality of life of these patients who do PET CT versus the standard, and how that's impacting their emotional well-being, because that's also probably and likely less taxing on the healthcare system. It's just a lot harder to prove. Yeah.
Well, I think the ICER price is per false positive averted, and so that's an indirect way of doing that. Colby, can you put that in perspective? What is $31? I mean, what is considered to be an acceptable
Sure.
ICER?
So let's say we have a group of 100 patients. Medicare would have to pay, and this is Medicare nationally, would have to pay $31 to ensure that one patient in that group of 100 could avoid a false positive, which we know has so much emotional toxicity and also just sets the expectation of added workup costs and things like that.
What is the what is the range of ICERs, and what is an acceptable? Is $200 an acceptable ICER? Is $1 an acceptable ICER? I'm just saying.
Oh, yeah. So generally, the accepted ICER is $100,000 per year. So I guess if you work that out per day, I think it comes out to like $200 per day. And so we're talking about an avoided false positive, which is 11 days. So you're paying $31 for this avoidance of an 11-day terribly intense anxiety period for patients.
So easily within the accepted standard. Okay, well, fabulous. Okay, Emma.
Over that. Hi, everybody. So for my biggest takeaway, kind of along similar lines, slightly different from Colby's, is not only to be really passionate and stay involved in your passions outside of work, but to also be really passionate about what you do at work. And I think it's been really inspiring watching Laura and all my other mentors lead with this passion, and you can just tell how much they care about everything, and they're optimistic, and I think it makes for a really nice, inspiring work environment. As for cross-pollination and who I've influenced or work with, I've worked with Emma McCune a lot this year. She does another DCIS study, and some of her patients have overlapped, and I think, she's trying to find a new treatment, and we're trying to use one of these studies to figure out what treatment's best. So, yeah, that's that. So without further ado, I'm going to present on one of the projects I've worked on this year, which has been the Oncotype DCIS cohort study. So I'm going to start just with the basic definition of DCIS, which is that it is a pre-invasive malignancy that grows within the milk ducts of the breast. And although pictures like this one sometimes are misleading, it does not always progress to an invasive cancer. It also represents nearly 25% of all the newly diagnosed breast cancers in the US right now, and it's usually identified by mammographic screening, which is interesting considering that before screening became really normalized and routine, it was only about 5% of the diagnosed cases. So we're clearly finding way more DCIS cases than we were before, which kind of begs the question of whether or not all of them are clinically significant, or if they would have ever had been found previously. So despite that question, the standard of care treatment for DCIS is still breast-conserving surgery plus radiation, and many women will actually opt for a mastectomy as an even more aggressive approach. And even with all of this early detection and aggressive treatment, there's been no concomitant drop in invasive cancer rates. So once again, this begs the question of whether our current approach to treating DCIS is in fact optimal, as we're not really preventing the truly life-threatening cancers. So there's definitely a need to personalize treatment based on a more individualized risk assessment. Originally, doctors focused on clinical indicators in order to try to define the risk assessment for patients, so things like the size of the DCIS, their margin status, cost, the age of the patient. And now there's also been a shift towards refining this assessment with genomic tests as they become more available. So one of these tests is the Oncotype DCIS assay. So it's a gene expression test that stratifies DCIS lesions into different risk groups. It looks at 12 genes in particular, 7 of which are cancer-related and might sound familiar, like Ki67, the PR receptor, and then 5 reference genes as well. And it's been validated in 2 separate studies to predict the risk of recurrence in women who are treated with breast-conserving surgery alone. And I think one thing that's interesting about this test also is the actual report itself. So it's a pretty long report that you get back, but I'll highlight some of the important factors. First is just the score itself, which is from 0 to 100, where the higher score is a higher risk. It also defines your risk of any recurrence of any type, and then specifically your invasive recurrence, which again is likely to be more clinically significant. It also shows the ER and the PR score for the patient sample. And then finally, the last page, which I think again is very important, shows the same information in a very patient-friendly manner, so using patient-friendly language and different schematics. So our study in particular is investigating how treatment decisions do or do not change when we use this DCIS score. So we're providing the DCIS score to 1,000 women who are facing an active management decision, and we're using tissue from previous core biopsy or a surgical excision in order to run the test. And we're giving out 2 decision questionnaires, once before the score and then once after the score. And these are taken by both the patient and the physician. So to go through the pre-score survey a little bit, we start by asking them what treatment recommendations they discussed with their doctor, and if they had to pick right now, which one would they go towards. We also ask them how important a set of various factors are, so things like the effect of the treatment on the quality of life, the possible side effects of the treatment, and the likelihood that the treatment will reduce the risk of getting breast cancer again. And then on the post-score survey, we have many of the same questions, but we also ask them if the Oncotype assay influenced their treatment decision, and if so, how they felt about the score. So were they glad that they took it? Were the results easy to understand? Did it support their treatment decision, etc.? So since the study opened in late September, we've consented 26 patients, and we've had 22 scores returned. The assay did fail 3 times due to insufficient carcinoma, and the score is still in process for 2 other patients. We've also had in our cohort a variety of DCIS characteristics, although it seems to skew towards the high risk based on pathology. And we've also had 27 patient surveys returned, which is what I'm going to focus on for the rest of the presentation. But notably, only 8 patients returned post-score survey, which is not a great response rate and is something that we should look to get up in the future. So when I was looking at the DCIS score distribution, I found one thing that was pretty important, which is that the Oncotype score seemed to skew towards a low risk. We actually had, as you can see in the light blue, we had 12 patients who were now defined as low risk, which was different from the pathology description. And to look at it even more specifically, again, the DCIS score seemed to deflate the risk. We had many more low risk, many less high risk. And more specifically, there were actually 4 patients who were high grade by pathology, but then low risk on the oncotype. Similarly, there were 5 who went from either intermediate to low, and then 4 who went from high to intermediate. And only 1 patient actually was increased in a risk assessment. So this showed that we're providing different information, not simply confirming what we already know or think we know about the patient's disease. And it also emphasizes the potential use in preventing overtreatment specifically of DCIS. And then I was also looking at some of the patient opinions that they reported on the surveys. And I found that 7 of the 8 stated that the score influenced their treatment decision. All 7 strongly agreed that they were glad that they took the oncotype test, and all 7 either strongly agreed or agreed that the test was easy to understand. And I think taken together, these things are pretty important and demonstrate the potential for the DCIS score to be used to reduce patient anxiety by empowering them and making them more knowledgeable about their disease. And then in terms of factors that were important to patients when making their treatment decisions, perhaps not surprisingly, patients generally reported that potential side effects were very important to them. Additionally, an effect on the quality of life was also reported to be very important to patients. And reducing recurrence risk was also one of the higher ones, although not quite as high as the other 2. And this, to me at least, confirms that patients might be seeking alternative treatments in order to maximize their quality of life, minimize their side effects while still reducing their recurrence risk. And I also thought it emphasized the importance of having an accurate baseline recurrence risk estimate, since it is something that the patients are thinking about when deciding on treatment. So in conclusion, the DCIS score seems to, at least now, provide additional and clinically relevant information by giving a more precise risk assessment than previously possible. And the score report is also, at least for right now, understood and appreciated by patients, which I think is important for possible shared decision-making between the doctors and the patients. And then patients also seem to heavily consider the quality of life and side effects when they're making their treatment decisions. So this seems to reiterate that they're not necessarily looking for the most aggressive treatment just for the sake of having the most aggressive treatment. And as for future directions, I think first and foremost, we need to enroll more patients. So hopefully we'll be able to start enrolling patients at other Athena sites as well. And then I think we also need to probably develop our workflow a little bit better in order to improve the survey response rate. So maybe doing online surveys, administering them by phone rather than just sending them to the patients and asking them to fill it out. And then I think we need to create an online database, which is something I've been working with Haley and Jesse, in order to allow for real-time data analysis that might affect practice. And yeah, I just wanted to thank my mentors, Laura, everybody.
So that's great. I think that just goes to show that there's a lot of grade creep from pathologists because everyone was so anxious. And I think it reflects what Joe said earlier, which is, clinicians are focused on trying to be as aggressive as possible. How do you feel? Do you feel that there's a direct comparison to the data that Fiona presented about what trade-offs people want?
Yeah, exactly. Yes, exactly. I think that is one thing that would certainly be included in terms of the effect on their quality of life. That patients are definitely thinking of things beyond just surviving or minimizing their risk of a disease coming back.
Yeah, and especially since it's not affecting their mortality. Then one other question, then I'll get to yours, is if the one source system was set up and implemented in the clinic, would that make a difference in what you're able to do and why?
Yeah, I think it definitely would. That was something that we were working on a lot in this year as well. I think it would definitely streamline the process. It would allow the doctors to get me, or Jane, I guess, as my replacement, to come down to clinic and consent the patients immediately rather than having to call them after the fact. It'd also make the doctor's life a lot easier because they could fill out their survey right away online.
On their phones.
Or on their phones, ideally, and so could the patients, and I think it would definitely streamline the process.
You pointed out that the DCIS score, you said, deflates the score compared to the pathology report.
Mm-hmm.
How do you know it's more accurate and not simply just an under-evaluating?
Yeah, I don't 100% know. I think that genetic factors are often really, really important and maybe less
Because what's the data?
subjective.
But they have data.
And they do have data. The score has been validated as well. So I think that that's also hopeful. Certainly. Yeah.
So I would say that pathology grade is not validated. This is validated. Again, what's happened too, it's very interesting, and this again reflects, which of course none of you is going to happen to you, but has happened over time, is that the old way of assessing DCIS, the Page was the pathologist, David Page was the pathologist who kind of organized this, but then people kind of reduced it and then got high grade stuff that was intermediate and low grade somehow became high grade. That's what I call grade creep, because we're like so anxious to make sure that people get as aggressive a treatment because we're fighting the war on cancer. There's a lot of that verbiage in what we do, and I think it's kind of led people down the garden path. Laura?
So I also found it interesting that the risk deflates, and so I'm actually not that much aware of the DCIS score, but in the DCIS score is made up of 6 genes, if I remember, or 8?
It's
And
14
so
totals.
It's 12 total. There's 7 cancer related and then 5 reference genes.
Okay.
So my question is estrogen receptor still part of those?
It's the progesterone receptor instead of the ER.
So the reason I'm asking is whether the deflation in risk is maybe associated with a higher expression of progesterone receptor, because that could also help you in putting up the argument that those patients specifically could actually be well treated with maybe low dose hormonal treatments to actually decrease their risk instead of like large operations. Or so I think it's worthwhile to look into whether the components of the genes, because I know more about the invasive cancer and the
That's been
estrogen receptor is actually a big driver of the score. So
well. They've actually shown this. So in their main cohort, they showed, again, this is in the ECOG study that they originally did this in. So when they looked at people who had lumpectomy alone and then lumpectomy plus hormonal endocrine treatment, you see this big reduction. Okay, now the other Emma.
Yay.
Okay, floor is yours.
Hi, my name is Emma. I'm the other Emma. So I guess I'll start with something that I've learned. Yes, I'm a number 1. No, I'm kidding. I'm Emma M. That was Emma I, or equals. And so I guess one thing that I learned during my 2 years here at the Breast Care Center is that you really need to take initiative in identifying problems and confronting these problems. I think, especially I've learned a lot about working with Laura, and I think it really helped me get a lot of the work that I wanted to get done here. And so I learned a lot about, initiative. In terms of how my project fits in with other projects, I think it's good timing that this is coming after Emma I's presentation. We worked a lot together on DCIS and characterizing different types of DCIS. And so while she just talked about, defining low-risk DCIS, I focused a lot in my past 2 years on defining high-risk DCIS and working to establish new forms of treatment for people with high-risk DCIS. So without further ado, I will start my presentation. These past 2 years, I've been working as a coordinator on what is known here as the DCIS Pembro study. And for my final presentation, I wanted to present some of our data from the study and specifically characterize the immune microenvironment of DCIS treated with intralesional pembrolizumab. For the presentation, I will start by just introducing the Pembro study, the DCIS Pembro study. I will present some examples of immune responders that we've seen in our analyses thus far, and I will share some other results from the study. In the DCIS Pembro study, we enrolled women with biopsy-proven high-risk DCIS that meets at least 2 of these criteria, and we administered 2 intralesional, so local injections of pembrolizumab twice, 3 weeks apart. And this was at a very small dose. We started with a 2 milligram dose, which is 1/100th of the approved intravenous dose that's given systemically. And we escalated up to 8 milligrams, which is 1/25th of the approved dose. And at the end of our dose escalation cohort, we've identified 8 milligrams as the highest tolerated dose, and we will move on in the rest of the study using this dose. This is a novel approach because, first of all, pembrolizumab hasn't been studied in the DCIS setting. It's used a lot in women with breast cancer and other types of invasive cancers, but it hasn't really been studied in the DCIS setting. Additionally, we're hoping to minimize the amount of systemic toxicities by administering a local injection at a very small dose rather than a systemic treatment that could cause systemic toxicities. We collected the diagnostic core biopsies and the surgical specimen from each patient that we treated, and we prepared tissue sections for immunologic assays to look at changes in the tumor immune microenvironment before and after treatment. I want to just show a very brief graphic of what pembrolizumab does to explain what we're trying to achieve in the study. So in brief, tumor cells have a way of masking themselves and evading the immune system through the PD-1-PD-L1 interaction. What pembrolizumab does is it is a PD-1 antagonist that binds to PD-1 and blocks this interaction and activates the T cell to recognize and attack the tumor cell. So we hypothesized, or what we're hoping to see with these treatments is that the T cells are essentially activated, and that after treatment we see this activation and infiltration of T cells in the DCIS lesion. So to characterize the immune microenvironment of DCIS treated with intralesional pembrolizumab, for my presentation I wanted to ask 2 questions. The first is, does pembrolizumab treatment recruit T cells to the DCIS lesion? And just for the purpose of this presentation, I'm just looking at CD3 T cells. So to do that, I looked at multiplex immunofluorescence analyses to characterize changes in the DCIS immune landscape before and after treatment. I then wanted to see if these recruited T cells subsequently infiltrate the DCIS lesion. To do this, I performed spatial distribution analyses to investigate co-localization of T cells and DCIS cells. In my analyses, I identified 3 immune profiles that I now want to go and show examples of. And so these 3 immune profiles are immune responders, immune non-responders, and immune partial responders. So before I go further, I just want to take a moment to explain what you're seeing. So on the left, those are the multiplex images. The DCIS you can see in the yellow, and the T cells that I will be focusing on in this presentation you can see in green. On the right, that's the spatial distribution analyses. So it's the same image, just presented differently. In the blue is the DCIS, and the pink are the T cells, and the lines that you see are connecting a DCIS cell to its nearest T cell neighbor. So for example, if you are looking at this one random DCIS cell, its nearest T cell neighbor is right there. So this is what someone's DCIS lesion looked like, their immune landscape looked like before treatment, and this is what it looked like after treatment. So you see a big infiltration of T cells to the lesion, and if you look at the spatial analysis, spatial distribution, you also see that these T cells are coming into the lesion, and it looks like they're infiltrating. To quantify this response, so you can see that there's a 31% absolute increase and a 4-fold relative increase in T cells after treatment. So the pembrolizumab treatment recruits T cells to the DCIS lesion. Furthermore, these recruited T cells infiltrate the lesion, so they're going into the lesion. To explain what this graph is showing, on the x-axis is the radius from a DCIS cell starting at 0 microns and going to 50 microns. On the y-axis is the percent of DCIS cells with a T cell in that radius. So we're interested in looking at 25 microns because it is said that cells that are within a 25 micron radius of a DCIS cell will be interacting with that DCIS cell. It's in that cell's neighborhood. So before treatment, 4% of DCIS cells had a CD3 T cell in that 25 micron radius, so in its neighborhood. After treatment, 60% of DCIS cells had a CD3 T cell in its neighborhood. So we can say that there is an increase in the interaction between DCIS and T cells following this pembrolizumab treatment. Now I'm going to show an example of an immune non-responder. So here we see what is referred to as an immune desert. There are barely any T cells in the microenvironment, and the ones that are there are very far away from the DCIS lesion. After treatment, we see pretty much the same image. So we can say that the pembrolizumab treatment did not recruit T cells to the DCIS lesion in this one case, and because there was no T cell recruitment, as we expect to see, there was no T cell infiltration. Before and after treatment, there were barely any T cells within the radius, within the neighborhood of a DCIS cell. Finally, we have this example, we've seen a few examples of a partial responder, a partial immune responder to treatment. So before treatment, we see another example of an immune desert where we don't see many T cells in the environment. And after treatment, you see more green at the bottom. You see these T cells coming, but you also see this halo around the DCIS lesion where it doesn't really look like the T cells are coming into the lesion. So we see here, we see a 12-fold relative increase in the amount of T cells before and after, or in response to treatment. And if you just looked at this metric, you would say that this patient showed a response to treatment. However, if you then look at the T cell infiltration, you don't see any infiltration. This is the same result as the immune non-responder that I just showed you. So it's interesting to think about why we see this response. Why do we see these T cells coming towards the lesion but not going into the lesion? Finally, I wanted to show data from all 8 patients who have gone to surgery who have received treatment and have gone to surgery. If you look at the graph on the left, that's the change in the relative percent of T cells. And it looks like 6 of the 8 patients had a dramatic increase in T cells following the pembrolizumab injections. However, if you look at the next graph, which is the percent of DCIS cells with a T cell within its neighborhood, its 25 micron neighborhood, that response rate seems to fall down. And you see that some more partial responders, like the last example that I just showed. So the next steps, we're moving on from our dose escalation phase to our dose expansion phase, and we can somewhat confidently say that, we can confidently say that this is a tolerable and feasible treatment for women with high-risk DCIS. None of the patients that we treated experienced side effects or adverse events or dose-limiting toxicities. And we can also say that this intervention results in changes in the tumor immune microenvironment. But it's interesting that there are variations in these changes, and I think it requires further investigation as to what's happening on this immune level, so that some people show full immune responses to treatment while other people show partial or no immune response to treatment. The next steps in the next phase that Harriet will be taking over, we will actually be adding 2 more injections for a total of 4 injections, and the hope is that by increasing the time between treatment initiation and surgery, and also increasing the amount of injections and doses, that this will help to heighten that immune response. And also we want to add an apoptosis marker to the panel so that we can see if this infiltration is accompanied by cell death. Ultimately what we want to see is, I think the grand image is that these injections will help DCIS lesions melt away and go away. And so what we want to see is that DCIS cells are actually being killed off by T cells. I would like to thank this team. Without this team, I wouldn't have these pretty pictures to show you. I would especially like to thank Mike, Laura, and Jasmine for being amazing mentors on this project over the last 2 years. And I'd also like to thank all the interns and the internship for the memories and the friendships, and for moments like these that make everything worth it. So yeah, thank you.
Okay, you interns, be thinking of your Halloween costumes now. Questions from the audience? Yes,
Is there
Frank.
any information on the treatment outcomes of full responders versus partial responders versus no responders?
What do you mean? Well, everyone went to surgery. This was a proof of concept to see whether we can get immune infiltrate. You mean, did anyone's DCIS go away?
Did it like shrink?
No, well, no. So that's why we've increased it to 4. But, let's see, did I see Mike in here? Yeah, so so Emma, do you speculate? Do you think that more injections of Pembro is going to do the trick, or do you think we're going to need something else? And how do you think we could answer that question?
I think more injections could do the trick. I think for the example of the immune partial responders, perhaps what they needed was just more of a boost, because the immune system is there and is doing something and just needs a boost. Maybe the trick is CPG or
Something, yeah.
But yeah, maybe something else does need to accompany. Does need to come along with the Pembro injections, because maybe the reason we see these partial responses is because there's another interaction between the tumor and the immune system that needs to be overcome to create that full response.
So one final thought-provoking question, which is, our model is that we have to see the DCIS destroyed. Is that necessarily the right thing? What if someone just had that DCIS and it sat there forever? Is there anything wrong with that?
No, there's not. I guess what I mean is the DCIS is potential to become something worse. That potential needs to be destroyed.
Right, yeah, and I think one of the things that I was struck by in looking at the retrospective study, who's doing that? Paul's gonna be doing that, it's just like, and maybe it's this study making us think, maybe there's a reason why people get DCIS and non-invasive cancer, and we always assume that something terrible is gonna happen. But maybe all we have to do is make sure it doesn't. Yeah, I think that would make people uncomfortable. But maybe all you have to do is, prime the response. I'm not exactly, that would be a time escalation study, or how do you think we'd sort that out? Watch.
The what? Yeah, I mean,
Give the Pembro and then
and
not
wait.
operate?
Yeah, you could do. It could be emerging, because one of the DCIS projects we have here is a surveillance study where you just watch and wait. It could be some kind of merging of those two, where someone receives Pembro injections and we just watch their DCIS over time to see.
Maybe to reassure those patients, we can find some markers of senescence. I think Jean-Philippe Coppet had some ideas to add to the panel maybe of.
Well, that's good, actually, because Mike, you wanted to add another panel anyway, right? To look at apoptosis and. Dr. McCune, any thoughts about what we should add to the third panel?
I have to take a movie of myself
Oh
as
my
I
God.
answer. Yeah, actually I do. So the exhausted cell that expresses PD-1 at high levels is a goner. What you want to do is recruit in these PD-1 intermediate cells that have the potential to proliferate and express functions, including infiltration and killing the cells. So I would suggest like adding on TCF1, T cell factor 1, which is the transcription factor that marks these cells and that allows them to proliferate, and CXCR5, which is a chemokine, which in viral diseases has been shown to be involved in infiltration of active CD8 T cells into viral lesions, and I think there's some data even with malignant lesions.
That would be, so that if we could show infiltration of CXCR5 cells, or just the presence of CXCR5 cells, that would give us confidence to watch, maybe to, do the injections. I mean, we'll do the expansion with the 4, but if we see the right kinds of cells there, that we could maybe give an extra 2 months or something and just watch people.
Yeah, that would be the confidence-raising boost. If you had infiltration of these proliferating cells that express chemokines that allow for infiltration, that's a good sign.
Okay, I love it. All right, well, thank you. Well, so Emma is going to recruit you to be an advisor to our project. Okay. All right. So thank you. Great job. All right, Jenny, the floor is yours. Start with your takeaway. What most important thing you learned?
So one thing I've learned, especially being involved in the quality of life space, which I haven't been before, is that we're really not doing enough. Quality of life has really become a forefront in the past couple of years, and we all talk about it, but really when we do have these measures, when we do have these scores, how often do clinicians look at them? How often do they integrate them into their decision making and talk about the actual surveys with the patients? So I really think it's a culture change and a workflow change, that even if we implement these surveys and have these results, how do we make them actually meaningful, not just for our trial, but for clinic and for clinical workflow, so would be applicable to Athena, to Wisdom, to all the patients who are facing these decisions. All right, so today I wanted to give you an update on the patient-reported outcomes space and quality of life space in the I-SPY 2 trials and share with you some of the exciting next steps that we are taking. So just as a reminder and to show those of you who haven't seen the study before, the quality of life study is a sub-study in I-SPY where we distribute surveys at critical time points in neoadjuvant chemotherapy in the I-SPY trial to patients, and also we distribute surveys until 2 years after surgery. And these surveys ask patients about social aspects of their treatment and also symptoms of their treatment. Some of the goals of the quality of life sub-study include assessing quality of life and toxicities in patients receiving neoadjuvant chemotherapy, and I will also add novel neoadjuvant chemotherapy in I-SPY, which is a really important aspect. We want to study impact of providing risk prognostic information to patients, so that includes telling patients that they've had past CR, telling patients that they have no residual cancer burden versus telling patients that they still have cancer. How does that impact their perception of their quality of life? We also want to evaluate differences in quality of life in patients who undergo a lumpectomy versus a mastectomy. So as I've mentioned, quality of life is really up and coming, and one of the things that we were grappling with was which measurement system should we use in our I-SPY population. Right now, we have 2 sets of measurement systems in our questionnaire that ask very similar questions to patients. One is EORTC. Developed in Europe, it is a legacy measure, meaning that it's been validated and used in many, many, many studies. And we also have a set of questionnaires called PROMISE, and PROMISE is developed by NIH. It is validated, but it's relatively new compared to EORTC. The reason that we have patients answer 2 sets of questions was to figure out if there are any differences in the data that we get from these 2 sets of questions and which one was better in our I-SPY population. So previously, actually last year, I presented on some of the data that we had regarding hormone receptor status, HER2 status, and the differences in quality of life when patients have those different characteristics. Today, I wanted to show you some of the steaming hot new data that we just got regarding age categories and also correlation of quality of life with pathological complete response. So physical function is a really important aspect of a patient's quality of life, and we wanted to see its correlation with age groups. So what we did was separate patients into 2 age groups, older than 50 and younger than 50. And keep in mind, these patients answered the exact same 2 sets of questionnaires at the exact same time. And both PROMISE and EORTC showed that patients' physical function, as expected, decreased throughout chemotherapy and after surgery slowly returned. Now, and they both showed that patients who are older than 50 experience lower quality of life as expected. Now, the difference is that EORTC, the graph on your right, showed a larger separation of those physical functioning scores. And patients who are older than 50 had significantly lower physical functioning, and these differences were significant at all time points except for 6 months after surgery. Whereas if we move to the PROMISE, you can see that the separation between the two age groups in terms of their physical functioning is smaller, and there's only significant differences at baseline, which is time point 1, and 1 year after surgery, which is time point 7. So we also wanted to look at physical functions correlation with pathological complete response. If you look at the graph on your right showing physical function scores, EORTC physical function scores of patients who achieved a pathological complete response versus the patients who did not achieve a pathological complete response, there were no significant differences in physical functioning. Whereas PROMISE actually showed that there was a significant difference and that patients who achieved a pathological complete response had lower physical functioning, especially after surgery. Again, fatigue is something that's really, really important as patients undergo cancer therapy. And when we separated patients into the same age groups, so above 50 and below 50, we found that EORTC on your right showed that patients had significantly less fatigue, while PROMISE showed no significant differences. But they both show the same trend, that fatigue increased throughout neoadjuvant chemotherapy and slowly decreased after surgery. And lastly, I wanted to show you what we found in terms of fatigue's correlation with pathological complete response. On your right, EORTC showed that patients who achieved a pathological complete response had significantly less fatigue, especially after surgery, whereas PROMISE showed no significant differences in patients who achieved a path CR or did not achieve path CR. So the conclusion is that the questions you ask matter, the measurement systems you ask matter, and these minute differences might be clinically significant, but we're still in the process of figuring that out. So we will continue to look at more variables than just physical function and fatigue, and we'll continually separate patients into more characteristics than just age groups and patients who had a path CR or not. And we will continue to explore if these differences are significant and how they apply to our population. And that's something that Haley is going to do. But in the meanwhile, I wanted to share with you some of the exciting next steps that are happening to the quality of life study. So currently, our quality of life studies are paper-based, and we are actually looking at, with Haley's help and with collaboration with OneSource, moving the quality of life surveys into an electronic platform to increase response rate and return information in real time, both to patients, to providers, and to our trial. We want patient-reported outcomes to be a key component of drug discovery and of I-SPY. And what that means is that we're going to be incorporating more frequent reports of symptom-based outcomes. And what I mean by symptom-based outcomes is fatigue, is nausea, vomiting, dizziness, things that are more acute and more and easier to manage. And we want these reports to inform adverse events and clinical care. And we want to integrate quality of life into the main study of I-SPY and make it a key feature of I-SPY. So looking ahead, patients can fill out surveys anywhere that there's internet, and the data will return real time to I-SPY trial, to physicians, and most importantly, to the patient. The patient should be able to see analytics of his or her quality of life survey. And this whole process will be managed by various groups like the Patient Reported Outcomes Advisory Board, the Quality of Life Working Group, and our Safety Working Group. And the data will be very integral to the trial, hopefully. Our new proposed survey plan, I wanted to highlight Pro-CTCAE, a new measurement system that we've added to our new survey plan. And Pro-CTCAE is very symptom-based, so it's asking very acute questions like, do you have dizziness, vomiting, and things that the clinician can address. For now, we've decided to put PROMISE into our survey because PROMISE is more modular and we're able to pick and choose the symptoms that we really want to focus on. We're also going to be asking more global questions about health. So instead of the more granular aspects like anxiety, depression, physical function, we're going to be asking the patient, how do you feel as a whole? And hopefully that can also inform our treatment decisions. And with that, I would like to thank sincerely the people who have helped me along these past 2 years. I can't believe it's coming to an end, but Dr. Melisko, Karen, Smitha, Adam, thank you so much, Jesse, and the whole iSpy team and the BCC interns. Thank you, guys.
Great. So, Jenny, in terms of thinking about toxicity, and our ability to reduce toxicity and make it a factor in how we make choices for how to assign patients, do you feel like it's ready for the prime time for us to choose some tools here to use in day-to-day practice?
Yeah, actually, the Pro-CTCAE that I just highlighted is for clinical use, so physicians can be using it right now.
But I'm asking specifically, if we are trying to do drug development and make choices about agents that have less toxicity, do you think these are the sets of tools that can be used?
I think combined with clinician, I think it should, in short, I think it's not ready, but combined with physician-informed CTCAE, I think it'll be better than what it is right now. So patient-reported outcomes and physician-reported symptoms together to inform a checklist.
Right. So I think the challenge in front of us, however, is to come up with a measure to help us adjust efficacy. I think we heard 2 presentations today that tell us that efficacy is not just all people care about. And maybe the right thing to do is do the same thing that Fiona did, and really thinking about what Emma did, and say, okay, what kind of trade-offs are people willing to make to reduce their toxicity? I think it's impressive how much fatigue there is. And that fatigue is out to a year. People take a year to 2 years to recover from chemotherapy, especially who? It's not the women of what age group?
Above.
Yeah, so especially older women, it's a big deal. So what kind of trade-off would people take, a 1% or 2% difference in efficacy, or 3% to adjust? I think it's so a Heli, and who else is assigned? Who else is doing quality of life stuff next year besides a Heli? And Ashley. Okay. So, and Ashley, I know you're interested in drug development, and so I think this is really important. Maybe you guys could think about doing what Fiona did, to ask for some of these trade-offs. I mean, again, it's just like a standard gamble, trying to figure out, well, don't need a lot of it, but I think what we're trying to show is, physicians may not care, but patients do, right?
Yeah.
Yep. Okay. All right. So so Kel, I think you're next.
Well, it's really hard to pick one thing that I learned this year, but I think one thing that will definitely stick with me this coming year and also beyond that is just the sort of interdisciplinary, inter-specialty collaboration that I've seen. A lot of the time, you know, I get to go to tumor board and I get to watch it happen, but I've also seen it in the clinic, sometimes following patients for more than one appointment or getting to work with different providers and sort of seeing the interaction and communication that has to happen and how really important that is, and not only between physicians, but also nurses, admins, MAs, everybody. And I guess this project has connections with several different other projects of interns here in the BCC, and some of those include, actually I would say I-SPY, because I know there's not a whole lot of ILC cases in the main trial, but it does happen. And I-SPY definitely does use MRI to evaluate response to neoadjuvant therapy. It's not the only evaluation tool that they use, but it is one. My own project, the Low Risk Registry, has a fair number of ILC lobular cases in it, and so this is definitely applicable to that as well because we do collect MRI data for that. And I also think, and I'll talk about this a little bit more in the presentation, that this particular type of data collection could benefit immensely from the checklists and the OneSource project. So Haley, maybe we can talk about that a little bit. All right, so today I'd like to talk to you about the accuracy of MRI for evaluating the extent of residual disease in invasive lobular carcinoma of the breast after neoadjuvant therapy. Before we get started, we have to have some background information on what is ILC. It is the second most common subtype behind invasive ductal carcinoma. It counts for about 15% of total breast cancer cases in the US. And this makes it much less common than invasive ductal carcinoma, but it still is the second most common subtype. It is characterized by the loss of the adhesion molecule E-cadherin, which causes the cells not to adhere to each other quite as well as they would otherwise, resulting in a very diffuse growth pattern. As you can see on these pathology slides, it tends to grow in much more single-file lines instead of clumps or clusters. And this growth pattern leads to some difficulty in discerning the size of ILC on imaging, and it also at surgery leads to higher positive margin rates because of this difficulty in determining the size and extent of the tumor. So in this subtype, there are several unmet needs, including better surgical techniques to improve breast conservation, as well as targeted therapy for ILC. But the unmet need that we're going to talk about today in particular is improved imaging modalities that might be a little bit more accurate at assessing the size of ILC. Here's our main question. Is breast MRI an accurate way to determine the amount of residual disease after neoadjuvant pre-surgery therapy in patients with ILC? And is there any correlation between changes on MRI before and after neoadjuvant therapy with any long-term outcomes such as survival and recurrence? Well, we searched several databases here at UCSF, including the surgical and pathological databases from 1981 to 2018, and identified 674 cases of ILC, performing chart review on those. Of those, we examined 136 cases which had neoadjuvant therapy and collected some BI-RADS features on those, which include the presence of mass and non-mass enhancement, as well as the maximal diameter and some descriptive features. And of those, we identified 101 cases for which we had a report of a post-treatment MRI, so pre-surgery after neoadjuvant therapy. And those 101 cases were the ones that are included in this analysis today. So this is our study population. There's a lot of things in this table. But one significant trend that we noticed was for those receiving neoadjuvant chemotherapy as opposed to neoadjuvant endocrine therapy. We saw that this population tends to be significantly younger in the top row, the p-value, and they're also significantly higher stage. So for our study population, we had, as an exclusion criteria, we had that they have to have MRI after neoadjuvant chemotherapy, but over 90% also had it before, had a report that we could access before neoadjuvant chemotherapy. And we found for the most part that most of the patients had some mass present, whether it was present with or without non-mass enhancement. Now, for those of you who might not be all that familiar with some of these MRI images, you will see that the mass, which is on your left, is a lot more circumscribed. You can sort of see where the border of it is, as opposed to the non-mass enhancement, which is much more diffuse. It's sort of harder to define where the edge of it might be. We compared the size on pathology, so that means at time of surgery on the excision, what was the size of the tumor, so the actual size, to the imaging size on the final MRI before surgery. And we found that in general, MRI definitely underestimates the size of the tumor in this population. You can see these box plots. There on the y-axis is pathology size minus imaging size. So if they were the same, you would expect the box plot to be centered about 0. But in fact, it's centered in the positive integers, which indicates that the pathology size tends to be larger than the imaging size. For masses, the pathology size tended to be an average of 3.3 centimeters larger than the imaging size. And for non-mass enhancement, it was 1.9 centimeters. And this tendency to be larger on actual size is true both for neoadjuvant chemotherapy and neoadjuvant endocrine therapy as well. There's very few cases, as you can see, where MRI overestimated the size of tumor. For masses, we found that if there was a large size discrepancy, so if the tumor was significantly 1 centimeter or larger, bigger on pathology than it appeared on imaging, this was associated with positive margin significantly. With this large size discrepancy, we had over 46% positive margin, and without it, we had 20% positive margin. So this definitely has implications for local control of tumor and for surgical control. We were also curious as to what the correlation was between MRI mass size and the size on pathology. So including all patients with masses in the chart on the left, you will see that the R, so the correlation coefficient, is relatively low. This means this is a weak correlation. And specifically, you'll see some cases where the mass size is very small, and yet the tumor size on pathology is quite large. So in these cases especially, it might not be all that helpful to look at mass size on post-treatment MRI. If you exclude cases with non-mass enhancement, the correlation becomes much better. It goes up to 0.67, and both of these are significant, but the correlation is much better, excluding patients with any non-mass enhancement on their post-treatment MRI. And when you just look at all patients with non-mass enhancement, there's basically no correlation here. Neither of these are significant, either if you include all patients with any non-mass enhancement or patients with non-mass enhancement alone, so no masses. The correlations basically don't exist. They're quite weak, and therefore this might not be that reliable in assessing the extent of disease. So we're seeing not that high accuracy. There is some correlation, especially with masses, but in all cases, they still do tend to underestimate the size of the ILC that's there. So what about the radiologist's subjective opinion about whether or not there was any improvement during therapy? Well, we assessed disease-free survival at 4 years and found that when there was an improvement subjectively on MRI, when the radiologist noted some improvement, there was 89% disease-free survival, and without improvement on MRI noted, it was 73%. This is a trend only. It's not significant at this point, but it's definitely something that we consider intriguing and look forward to investigating further in the coming year. One thing that definitely was significant is that if the radiologist noted interval progression, so if the tumor progressed during the course of neoadjuvant treatment, this was definitely associated with increased recurrence, up from 18% to 80%. So this is definitely a signal that there might be an increased risk of recurrence. And you can also see in this picture an example of a response to neoadjuvant therapy. In the red circle, under the before slide, there's a suspicious finding, and then next to it, afterward, that suspicious finding is much significantly decreased. In conclusion, MRI does tend to underestimate the size of ILC after neoadjuvant therapy, and it's true including both chemotherapy and endocrine therapy. And it has potential implications for margin status, especially with the masses that we found there was a significant increased risk of having a positive margin in cases where there was a large discrepancy. And although it underestimates the true size, there's at least a stronger correlation in those who have mass only as opposed to those who have either non-mass enhancement or non-mass enhancement alone with no mass. And so MRI in this population may be more accurate at assessing size of masses than non-mass enhancement, although there still does tend to be that trend of underestimation. And the difference in disease-free survival based on improvement in MRI definitely merits further investigation, and that's something that we look forward to continuing to explore. For future directions, we're hoping to expand this analysis to include both mammogram and ultrasound data in the similar pre-post neoadjuvant therapy structure. We have collected that data, we just haven't put it into our database yet. We are also going to continue to add more ILC cases and perform this analysis and gather follow-up data on previous patients as we go along. And we're hoping to work with breast imagers to maybe come up with some better predictors and more accurate descriptions of tumor size, including total tumor volume rather than maximum diameter, which might not be the most accurate way to assess it. And I also think that based on reading a lot of MRI reports, checklists could be very beneficial here because there's a lot of inconsistency in the terms that are used, and sometimes certain terms are left out and not in other cases, and checklists could definitely help standardize that. Thank you so much.
That's great. So, I mean, one thing that really strikes me, so it's almost, the opposite. We know in ductal cancers, when you have mass-only MR, that it's actually that we've looked at clinical exams. A clinical exam overestimates the size, and MR is more accurate versus the other way around for these kind of more diffuse masses. So, I think that's a feature of lobular cancer. It's more diffuse, so it's going to be harder for MR to capture it. I think one of the most important things that comes out here is the NME. And the fact that there's absolutely no correlation with size and extent of disease suggests that the radiologists, should they be recommending biopsy of all this NME then? Do you think that's some feedback?
Well, biopsying all NMEs is often there's multiple ones, there's many of them are focal. That sounds like it's not going to be feasible.
Yeah. Well, but it actually, I think this is actually really important because people worry, and the radiologists particularly, they just want to not miss things. So all this NME that they're talking about, and so often I'll just say, I'm not biopsying this, I'm not going to biopsy that. This actually gives a very quantitative reason for saying NME is not something that you need to necessarily go after, especially in a setting of a lobular cancer. It's not that meaningful. I think that's actually warrants a lot. And I love the fact that the progression, I mean, that's important, but maybe we can hone in on how to better quantify that response for looking at this. And this is in the, and this is the low-risk registry, right, partly, or?
Some of these
both?
patients are also in low-risk registry, but
Yeah.
most of them are not.
Yeah. Well, we can, and actually, it might even be useful to extend this not just to lobular, but to everybody. That's really interesting, I think. Okay, any other questions from the audience? Okay, fabulous. Great job. That's a really hard topic. Thanks so much. All right. Latina, you are on deck. Come on up. And you're going to talk about pathways, right? And compass, yeah, great.
So for the last 2 years, I've been fortunate enough to wear a few different hats in the Breast Care Center, both as a drug trial coordinator and then a coordinator of these 2 psycho-oncology programs. And I think what I've really realized is that it's really important to treat these psychological interventions just like we treat drug trials and surgical interventions, with the same care and attention. And I've been super fortunate to work with Diane Shumay and Michelle Molisco on these evidence-based approaches in the hopes of giving patients the most meaningful and full quality of life. So With that, I want to introduce the Pathways and the Compass programs and their feasibility and acceptability in the UCSF Breast Care Center. So as you know, acute cancer treatment, so chemotherapy, surgery, and radiation, is associated with a spectrum of potential side effects and long-term toxicities. I'm not going to name all of these, but some important ones to think about are chronic fatigue, infertility, sexual dysfunction, cognitive dysfunction, depression and anxiety, and all the physical side effects that are often related to hormonal therapy. But some underestimated long-term effects of cancer diagnosis and treatment are anxiety, fear of recurrence, and a return to normalcy. And I think a lot of patients feel a pressure to return to normal, to return to the way to have their life return to the way that it was before they had treatment. And so obviously the goal of treatment is to make our patients feel better, but oftentimes they leave they come out feeling unexpectedly worse. And so it's really important to address these long-term effects. So keeping this in mind, somewhere along the way, Laura met a man named Greg Hicks, and he's an organizational consultant, so he's worked with various companies like Google and Wells Fargo, Walgreens, to help enrich the collaborative environment and enhance teamwork in organizations. And so Laura thought, what he was doing was super interesting, and he also came here and did some consulting work in the breast care center, and she thought it would be interesting to see how his model would apply to the breast cancer population. So with that, the Pathways program was born. And I just want to give you a little bit of background on this model. So Greg and his partner, Rick Foster, they traveled around the world to over 30 different countries across 3 years. And they wanted to interview people that were self-proclaimed happy. So they went to villages in all of these different countries. They put ads in newspapers, and they asked people to come forward so they could interview them, people that were self-proclaimed happy. And so after collecting all of this information with case studies and anecdotes in all these different countries, they thought they would find differences in happiness. But really what they noticed was that there were 9 universal behaviors that all of these happy people were displaying and were doing. So these behaviors are associated with a high level of resiliency, the ability to manage emotions, and show improvements in overall quality of life for the people. And I'm not going to go through all of them, but they're truth, accountability, identification, centrality, recasting, options, appreciation, and giving. And at the center of all these behaviors is something called intention. And intention is really just letting others know what's really important to us.
You still have to read the book, though.
You still have to read the book. I'm not going to spoil anything. And if we practice intention, we create stronger bonds with our family, with our friends, and we also can achieve our goals in a more meaningful way. So how the Pathways program works in the Breast Care Center, we recruit patients who have completed their acute care. RSVP and invitations are sent out by a nurse navigator. And patients are electronically consented via a baseline red cap survey. And then the workshops are held on Saturdays. They're about 8 hours with a lunch break. And at the workshop itself, it just consists of various group activities and exercises that help the patients learn each of the 9 behaviors over the course of the day. And then we follow up with patients at 1 week, 6 weeks, and 6 months post-intervention. So I wanted to get into some of the surveys that we're using, some of the measurements that we're taking from patients. We're looking at the PROMIS anxiety and depression short forms, and the AAQ2, which is the Acceptance and Action Questionnaire. And this is important because it measures something called experiential avoidance. And experiential avoidance is really just moving away from uncomfortable thoughts or feelings, even if these uncomfortable thoughts and feelings will serve us well in the long run. So even if they're good for us in the long run. And it also measures something called psychological flexibility, which is the opposite of experiential avoidance, or moving towards things that make us uncomfortable, but we know are good for us in the long run. And so this is an inverse relationship. And then we looked at the HIP-10, which is the happiness index profile. And this is a measure of something called locus of control. And locus of control is the degree to which people believe that they have control over the outcomes in their life, as opposed to external forces that are beyond their control. I'm going to explain some of the patient demographics. So we've had 7 groups thus far. Between September 2015 and June 2018, 63 patients have enrolled in all 7 groups. The average treatment length for all of the patients was about a little over half of a year. And today I'm just going to be focusing on groups 1 through 6 because we don't have data back from group 7 yet, but so 51 patients total. And 74% of our patients were Caucasian, 62% had a graduate degree, and 56% earned greater than $100,000. And we also collected patient and tumor characteristics. These aren't important for this presentation, but will definitely be important for future analyses. So now I want to get into a little bit of the results. So we looked at the HIP-10, which is the measure of the locus of control, and the AAQ-2, which is the measure of experiential avoidance, and saw that if you compare the end of intervention responses and the 6-week responses, locus of control increases significantly from baseline, and experiential avoidance decreases significantly from baseline. And so we hypothesized that if these measures are trending in the ways that we expected, which they did, that anxiety and depression will also subsequently decrease, and patients will have an overall improvement in quality of life. So then we looked at the results of our anxiety and depression measures and did see the same trend. So from baseline to the end of intervention, there was a significant decrease in both anxiety and depression, and also at the 6-week time point. But then if you look at the 6-month time point, there was no significant decrease. And we think this can be attributed to the fact that only 3 of the 6 workshops have included a 6-month follow-up. So this time point has only been reached for 2 of the 3 groups. And so we've only had 13 out of the 20 possible people respond to this survey. So it's a very small sample size. So just some of the patient testimonies and evaluations. One really standout quote from a patient. She said, "This was so not what I was expecting and so what I needed to hear. I'm leaving with much more hope than I walked in with, and tools to sustain it." And then when asked how worthwhile the program was, people rated it with a 9.7 out of 10. When asked how effective Greg Hicks was as the program facilitator, he received a 9.9 out of 10, so clearly people love him. And then when asked if they would recommend the program, 100% of our patients said they would recommend it to others. And then just some of our survey completion stats. 100% of people completed the baseline survey. It was still high at end of intervention and 6 weeks, but like I mentioned, we only have a 65% response rate at 6 months, so we're working on increasing that in the future. Some limitations: participants wanted less information at once. It's kind of a long day and a lot of information for them to retain in one day, and they wanted smaller groups so they had more time to share. And it's a homogeneous sample, like I mentioned. So I think some next steps are to implement some new survey questions that we think will better embody and measure quality of life. And then we want to offer refresher sessions for patients at 6 months so we can enhance their recall and make sure that they're still following these 9 behaviors and recommendations. And then we want to hold a workshop for young women only. And then, like I mentioned, I think it'd be super interesting to offer this to more heterogeneous populations. So maybe at SFGH or across all the I-SPY2 sites and the Athena sites. So I know I don't have a lot of time, but I still have to get through the COMPASS program. So introducing the COMPASS program, it's based on the intervention called ACT, which is Acceptance and Commitment Therapy. And so what acceptance and commitment therapy is, it is basically a therapy that teaches mindfulness skills to help patients live and behave in ways that are consistent with their personal values while they develop psychological flexibility. And it's been used to treat test anxiety, social anxiety, OCD, psychosis, chronic pain, and substance abuse. And now there's growing empirical evidence that it is addressing psychological symptoms in the cancer setting. So we hypothesize that ACT will help UCSF cancer patients confront experiential avoidance, enhance perspective taking, clarify and define their personal values, and promote behavior change in the service of their chosen values. And an example of this, of me acting in my own personal values, just to give you guys a better idea of what this looks like, is despite the feelings of discomfort of being up here giving this presentation, I'm moving through my value, moving through these just uncomfortable feelings, because my value is to disseminate this information to you all because it's important to me. And so that's an example of ACT in action. Our methods, very similar to the Pathways program, except this is a 7-session group intervention. All UCSF cancer patients are eligible regardless of stage and gender. We measured the same things as the Pathways program, except we had a fear of cancer recurrence inventory severity scale and a valuing questionnaire. And then we took the same time points as Pathways. So some of the demographics, we've had 6 groups thus far. 84 patients have enrolled in the program. The mean age is 74 years old. 22 people have completed all 4 assessments. And then of note, I mean, these are very similar demographics to Pathways, but 58% were breast cancer patients. The rest were other various cancer types. And then 30% of our patients had metastatic disease. So some of the testimonies and evaluations, we had really high ratings of the program and the facilitators, and 95% of the people said that they would recommend this to others. So this showed satisfactory acceptability of the program. One patient said, "I thought this program was highly worthwhile. I entered anxious and depressed about my post-cancer life. The program gave me support, a safe place to share my concerns and fears, and real tools to help me deal with my self-doubts and my anxieties." And so I also want to show you some of the results. So we hypothesize that if measures of psychological flexibility or experiential avoidance decrease, progress in valued living, or if our patients actually moving into their values, are they living by their values? That's progress in valued living. And then we looked at the HIP-10, are they actually increasing their locus of control over time? And so we hypothesize that if all these measures move in the right direction, that anxiety, fear of recurrence, and depression will all also significantly move in the right direction. And so you can see that here all these measures are significant from baseline to 6 months. So that it has a bit of a long-term benefit. So then when we look at anxiety, depression, and fear of recurrence, you can see that anxiety and depression decrease significantly from baseline to each of the time points. And then what's interesting is when you look at fear of recurrence, it does decrease significantly from baseline to the post intervention time point, but we actually don't expect fear of recurrence to go away. We're actually just teaching people how to have a different relationship to it. So not getting rid of it, but rather just changing the way they react and have it interfere with their quality of life. And so there are some future directions and limitations. We're recruiting for Group 7 for September 2018. We're improving our follow-up assessment adherence. And just some limitations, the broad patient eligibility criteria yields a self-selected convenience sample that's heterogeneous in cancer stage and type. And with that, I want to thank everyone up here. Thank you for an amazing 2 years. It's been nothing short of amazing. I said amazing 5 times, but thank you.
And part of the patients that you see, they're a little bit different. So someone has to be able to commit to coming, every. How often are the Compass?
So it's across 7 weeks. So if they have many comorbidities, it can be difficult.
Yeah, or
to
live
make sure
far.
that they
It's
come to all
harder.
of them.
It's harder to distribute.
Yeah.
So let's go ahead and change. If you were to think about if we had sort of an integration, sort of thinking about, the Red Cap surveys and the One Source projects, how could you imagine that if we were using some of these questions, would you say that we should take some of these questions about fear of recurrence or whatever to have instituted as a standard so that we can understand how to better find patients who should
Yeah.
come to these courses, or?
Yeah, and that's what I meant to mention in terms of
Over here.
cross-pollination. I think it's super important that we're continuing to utilize like the Athena program and the Calm Project to help identify patients that have high baseline anxiety and depression, and then we can refer patients into programs like this if they have really high baseline depression and anxiety.
So having the ability to pilot some of these tools is good, but once you have something, to be able to have it as a standard.
Right.
And then I think this is one of the points of research and care. Part of what you want is to have learning about how people are functioning and surviving should actually be part of care and not just a research study. So it's great. Thanks.
Thank you.
Great job. Okay, Molly, floor is yours.
Hello, everybody. Just take a moment to take a deep breath. I know we're getting through a lot of presentations, and I want you to listen to mine, so you should pay attention. In terms of what I'm taking away from this year, definitely going to be patient advocacy. We're in a really fortunate position in that we can afford extra time to go the extra mile for patients, to look over their schedules twice, to spend an extra hour trying to figure out scheduling conflicts and just make their overall process in the breast care center a lot easier. So I've been really grateful that I've been in a position to do that. Cross-pollination is going to be quality of life for patients. I'd like to say I cross-pollinated with myself for cold caps, but that doesn't count. So I'd say working with the Young Women's Registry with Fiona, looking at what really matters to patients throughout their chemotherapy journey, how I've been cross-pollinating. So, if you guys have ever found yourself in the infusion center walking through and you've seen this interesting new trend of patients sporting these bright blue mitts and socks, and you're thinking to yourself, is this a trendy new fashion statement? Is it a bunch of germaphobes coming through the infusion center for chemotherapy? It is actually a brand new use of cryotherapy, thought to help prevent one of the symptoms associated with chemotherapy. Okay, great. So I will be talking about three main topics for today. The first is going to be mechanisms of cryotherapy, why this is thought to work. Second is going to be neuropathy and those frozen mitts and socks I just mentioned. And third will be current research in this area. So what is cryotherapy? It is the medical use of cold therapy to treat a variety of ailments. These uses include relieving muscle pain, preventing post-operative swelling, and to prevent hair loss caused by chemotherapy, which is what I'm working on as cold caps coordinator now. Proposed mechanisms as to why cryotherapy works. There are two hypotheses right now. The first is the method of vasoconstriction. Second is the method of metabolic rate. So what are those two hypotheses? First mechanism is vasoconstriction. This is the idea that by cooling the peripheral arteries of the scalp, we are reducing the overall blood flow to hair follicles. This reduced blood flow results in reduced chemotherapy drug uptake. So the hair cells don't experience the full dose of chemotherapy. Other proposed hypothesis is that by cooling the cells, we're reducing their metabolic rate. We're decreasing their metabolic rate, meaning they're not as proliferative, they're not dividing as quickly. So they're hence less susceptible to the cytotoxic effects of the chemotherapy. So chemotherapy-induced peripheral neuropathy, I'm going to be calling it CPIN because it's a bit of a tongue twister. The problem we're facing right now is CIPN. So this is a neurological side effect of chemotherapy characterized by numbness, tingling, burning, or loss of sensation in the fingers and toes. It's thought that the incidence of neuropathy can be anywhere between 2 and 33% in breast cancer, and as high as 68% in all cancers, with neuropathy persisting in about 30% of patients at 6 months or later after chemotherapy. And neuropathy is something that's extremely important to patient quality of life as it impairs their ability to return to normal daily functioning. I had one patient who was seriously considering refusing chemotherapy because she was a violinist and she was really worried about the impact this would have on her treatment. And beyond the personal measures, CIPN also poses a significant financial burden. So one study found that for all cancer types, it poses a burden of $17,344 compared to control, an additional burden of that, and $16,940 in breast cancer patients specifically. So these healthcare costs include inpatient costs, outpatient costs, annual costs associated with oncology, and then drug and medical costs to treat the neuropathy. So the solution are these frozen mitts and socks. These were not originally intended for use for chemotherapy. They were actually just used to reduce normal daily swelling or pain in fingers and hands. And so someone got creative and decided to use these, the method of cryotherapy, to help prevent neuropathy. So there's a study that just came out this year by Ishiguro et al. It was a study conducted in Japan. It looked at a cohort of patients who were all receiving weekly paclitaxel, weekly 1-hour Taxol. And the patients would wear the frozen mitts and gloves on their dominant hand and foot for a total of 90 minutes for a 15-minute pre-cool, paclitaxel for 1 hour throughout the whole infusion, and a 15-minute post-cool. And they changed their gloves once throughout that time. Important to note that no patients dropped out due to cold sensitivity in this trial. So in terms of the objective symptoms, cold mittens objectively helped prevent neuropathy. This was measured by tactile sensitivity by the Semmes-Weinstein monofilament test, basically looking at the decline in tactile function from baseline. And so patients reported that for 27.8% of patients, they reported that they felt neuropathy in the hand and foot with the gloves on, and 80.6% of them reported neuropathy in the untreated hand and foot. And so this was based on the monofilament test. It was a more objective measure. In terms of subjective measures, the patients were questioned using the PNQ, the Patient Neuropathy Questionnaire. And it was found that the incidence of neuropathy was 2.8% in the experimental cohort on the experimental side, hand and foot, and then 41.8% in the control. And this is a statistically significant difference. Interestingly, CIPN also incurred, the onset of CIPN was earlier in the control side than in the experimental side. The authors also looked at reduced numbness as measured by perception of warmth or cold, and the decline in this ability to sense these temperature differences. This is not as statistically significant for the perception of warmth and not statistically significant for the perception of cold, but interesting that clinically that there was a difference. In the interest of time, I'll pass through the findings for the socks as well. Basically identical to the mitts in that they were statistically different in preventing neuropathy, both subjectively and objectively, and a clinically significant difference in perception of heat and cold, but not statistically significant. So all this is sounding pretty great, pretty promising findings, but as is the case in science, things don't always go your way. And the mitts and the socks were recalled. They were recalled voluntarily because there were 2 incidences of frostbite to patients who were not happy with the results of these caps. So now the question is, this is just one brand of frozen gloves and socks. So what is the role of these mitts and socks in our infusion center today? Do they have a place in preventing neuropathy? So one of my thoughts as to how this could be, a solution for this problem is to prevent cold toxicity in patients. So instead of allowing our patients to keep the mitts and socks in our medical grade freezers at a temperature of -35 degrees Celsius for weeks at a time, we would have patients freeze the mitts and socks in their kitchen freezers
Overnight, kitchen freezers don't exceed a temperature of 0 degrees Fahrenheit or negative 18 degrees Celsius, and then have them bring the mitts and socks to the medical grade freezer on the day of infusion. These medical grade freezers are negative 35 degrees Celsius. However, it takes penguin cold caps 72 hours to reach the negative 35 degrees Celsius from room temperature. So these mitts and socks would not reach this coldest temperature of negative 35 degrees. And then the patients would be able to exchange the mitts and socks. During infusion, we make sure that they're aware of the risks of keeping these mitts and socks too cold and use them in a safe and effective way. Another option might be a difference in concept. These are some kind of silly pictures of what the future of cold mitts and socks may look like. The reality is that we don't need the entire hand frozen. We're really looking at the extremities, the fingers and toes. So if you're looking to patent a new frozen mitt and sock idea, you can talk with me in the back afterwards. So thank you to everybody who helped make this project possible, to Dr. Ruga and Dr. Melisko, who are now considering studying this phenomenon, as there hasn't been a very robust study in the United States, to Tricia Strong from Dignitana Elastigel, and all the sage outgoing interns and bright new interns. Thank you.
I'm glad you found a use for all those freezers that I own in the infusion. I'd hate to think that those are going to waste now that we have Dignitana up there. So are people bringing those in and using them now? Mm-hmm. A lot of people. Mm-hmm, mm-hmm. And so the cold sensation was, in spite of feeling cold during the infusion, the idea is because they don't have the neuropathy, they retain the ability to discriminate sensation. Mm-hmm. And the extremes and did you show that it changes the extremes of toxicity, the extremes of Taxol toxicity?
Yes. So there was this statistically significant difference in the prevention of neuropathy, specifically for paclitaxel. So I guess just for everybody's information, taxanes and platinum drugs, so paclitaxel, docetaxel, and then carboplatin, cisplatin, oxaliplatin. Those are the regimens that are most frequently associated with neuropathy. So this Japan study looked specifically at paclitaxel patients, weekly 1 hour Taxol, so not in the other regimens. So that's still an area for research.
Yeah. So just for the people who aren't used to it, so someone who gets extreme neuropathy can lose the ability to walk, actually. That's how bad it can be. It's interesting that we're looking at, again, we don't understand who gets it. Hey, Laura V., this is sort of one of the things, remember we funded Diana Kreutz to look at who's predicted to get it. If we actually had a better idea of who was going to get it, you could target who should use these versus who doesn't, because most people don't get bad neuropathy, but everyone gets some, right? Mm-hmm. Everyone gets some, and just some of it's bad. So that might be a way to show that. Yes.
Is there any studies about the correlation of using these mitts and gloves with efficacy, so recurrence prevention?
Yeah, so that's definitely, so the short answer is no, there aren't any studies looking at that. The correlation of that is that we're in an ongoing follow-up of our Dignitana study looking at the risk of recurrence as scalp metastases, the worry that if you're not providing the full cancer dose, is it somehow impacting your risk of recurrence? So far, our findings have been that if a patient does have a scalp metastasis, it's not the primary site of recurrence. So it's one of many.
I would say many studies need to be done. I don't think that one needs to be done. I've never seen anyone with a MET in their fingertips or their toes. So I think we could just call that a wash and move on.
Call it good.
All right, Nick, you're up.
All right, glad everyone's awake. Now I can put you all back to sleep. Okay, so for me, my real takeaway this year, it's been really great to work on a couple projects, really kind of from start to finish, like particularly this one will hopefully finish, we're almost there. But so but in doing that, I think I've learned a lot about kind of staking out your voice in research and academia and everything like that, with so much help from you, Renee, and Laura V, so thank you so much. But, it's pretty rare that we have a program like this where people invite you to come and kind of stake your claim and show your research. So learning how to, force my way into that space outside of a program like this has been really invaluable. I think I'll take that going forward. So without further ado, here's some of that research. So basically, we wanted to look at smoking and breast cancer in the Athena population here at UCSF. So there's been a decent amount of research on smoking and breast cancer in the past, but the jury's kind of still out on the association between the two. Obviously, there's a clear link between smoking and lung cancer and a lot of other types of cancers. But we want some more conclusive evidence, so we thought we'd use this huge Athena population that we have to start to investigate this question. And so in doing that, we took the Athena Breast Care Center populations from UCSD and UCSF, and altogether that brings us to about 1,500 smokers and about 4,000 non-smokers. And about 108 of those have over 30 pack years, which is a metric from the smoking literature, which equivalates to a pack a day for a year. So it's a metric of exposure. And so the analysis I'm going to present today is only using the UCSF numbers because we're still waiting on, we have the UCSD numbers, they're incorporated here, but only about 2/3 of these come from UCSF, and we don't have the actual data from UCSD yet. So anyway, we took these patients and created a case control study where smoking is the exposure. And obviously the first thing we wanted to look at is the prevalence of breast cancer between the two groups. So for smokers, we find a significantly higher rate of breast cancer. You can see this trend here. What is that clicker? You can see this trend here that, as your smoking exposure goes up, so does the rate of breast cancer and DCIS combined in this graph. I'll show just invasive on the next slide. And so the odds ratio, if you're a smoker, is about 2.26, and that's significant. I have a relative estimate here, but it's relative risk here, but it's actually odds ratio. And if we kind of show that as a projected risk over your lifetime, that puts the smokers in blue here at a significantly higher risk throughout the time. So this is just kind of that odds ratio put into a visual representation. And so here it is for invasive disease, and you see that odds ratio goes up very slightly to 2.3, and it's even more significant. And again, you see the same trend that as smoking exposure goes up, so does the rate of invasive breast cancer. And again, to represent this another way, really, Zila's helped me a lot with these graphs, and really kind of what it equates to is that if you're a smoker, it's almost the equivalent of being 10 years older, which, as age being one of the most clear risk factors we have for breast cancer, that's a really significant jump. So as we start to look at this and see these trends, I controlled for age in all these analyses, but we also want to start thinking about certain confounding variables. So we know that a lot of smokers also have a higher rate of alcohol consumption, and that's a known risk factor for breast cancer. So here I incorporate alcohol consumption. You can see there that this is the rate of regular drinkers, which is defined in the literature as 1 drink a day over the course of a month. And so you see that the rate of regular drinkers does go up with smoking exposure, but if you look at the actual odds ratio, we see that it only drives down the odds ratio for smokers a little bit, and it's still statistically significant. So there is some confounding effect here, but it doesn't seem to be enough to kind of discredit the impact we're seeing from smoking. And another thing that kind of emphasizes this fact is that if we look at the difference from one pack year to another pack year, we see a significant difference as pack years increase. So it's not just being a smoker or not a smoker, and again, that's kind of represented in this graph, that as pack years increase and smoking exposure increases, so does your risk of breast cancer. So that's kind of the first question we wanted to answer, and I think there's a pretty clear trend here. We also want to start to look at biology to see if there was any kind of significant difference. And I'll let you know right now there are no significant differences. The numbers are too small, I think, really, in our study. We only have pathology for a limited number of the UCSF patients. So we're trying to expand that, and that's going to be one of our main steps going forward. But nonetheless, I want to show you some interesting trends. I think Laura and I really expected to see kind of a higher rate of, let's say, triple-negative disease or more aggressive cancer biologies. And at least so far, that's not what we're seeing. So here's HER2 positive. It has the clearest trend, which is why I'm showing that here. but you see that the number of HER2 positive patients really kind of drops off with smoking exposure, and there's the p-value down there. And I did that for a number of other things. So for hormone receptor negative and even triple negative here on the right, you'll see that the rate as smoking exposure goes up seems to decrease. Again, these are really not significant. I didn't even put the p-values because they're like above 0.5. So we shouldn't put too much weight into this, but so far it's just something interesting I wanted to address. And again, here's the number of kind of what we're defining as low-risk tumors, so ER positive, HER2 negative. It seems to kind of trend upwards as smoking exposure increases. But this is really complicated. So part of what could be driving this is the 5-year higher age among the smokers. So all these little asterisks are the significance values. So the smoking population is a lot older, which is what all of the significance analyses I was doing that shows that this is significant, incorporates that age factor. And so that's probably one of the main driving factors in these biological trends that we see. So we really are gonna have to bump up these numbers if we wanna start to unravel any trends there. Also, I mentioned that there's higher rates of alcohol consumption. There's also higher rates of obesity and comorbidities in the smokers. Nothing too surprising, I think, to what you'd expect to find, but it's just everything that muddles the data a little bit. So going forward, we've already sent this off to San Antonio, or we are sending that off today, and we're really just working to incorporate the UCSD data that we have available to us already, pending kind of a data agreement so they can share with us the actual numbers, and also expanding that pathology. And I didn't mention this on here, but I think it'd be really valuable to turn this into a cohort study and look at the larger screening Athena population we have and look at incident breast cancers among those and see what kind of trends we see in that population as well. So that's pretty much it. I wanted to keep it pretty short, but any questions? And thank you so much to all the Athena teams and the Lauras and Irene. So.
Great, thank you. So Nick, a lot of people have looked for the relationship between smoking and breast cancer. Been a lot of epidemiology studies that haven't seen this. Why do you think that is? Why do you think this data might be different? Do you have any explanation for that? And you will definitely be asked that question. So.
Yeah. I mean, I think the jury's still out. There's a lot of studies that have shown the relationship, and there's some that haven't. And I think it really just comes down to a lot of what some of these studies are controlling for and things like that. So in really large studies in really large cohort studies where you're seeing this kind of lower rate of breast cancer among these patients, I wonder what kind of the competing comorbidities are that are maybe coming in before these, what look like kind of later stage, if you have a high rate of lung cancer, for example, and the people who are more prone to getting cancers are kind of dying out at a younger age, and if it's true that the trend is towards these later occurring, more indolent breast cancer tumors, then it's possible that some of those are kind of being lost in your sample of healthy population.
So Stan Glantz, of course, loves this data, but I think again, we had made a commitment when we started Athena that we would incorporate smoking. I think that's actually one of the things that's nice about our cancer center, that one of the established programs is the tobacco control program. And I made a commitment to him that we would incorporate this into our Athena surveys. The one thing that we wound up dropping because of the length of the survey was secondhand smoke exposure. So Renee and Allison, I think on the basis of this data alone, I would like to move to the executive committee that we add the secondhand smoke exposure and make sure it's actually in wisdom on an ongoing basis, because I think that this is, potentially, you have to look for it, and you have to look for it in a uniform way, and I think that was part of Stan's pitch. So, congratulations, and thanks for asking the question, and thanks for looking. I'm sure Stan Glantz will send you a present. Okay, so good person to have on your side. Well, the other Nick, please stand up. No, it's like, Patrick, come on up, the floor is yours.
My two most memorable things are things that have shaped me about the internship program. First is
that there's always opportunities out there, and that it's up for you to advocate for yourself to go out and get them. The second is optimism. I was at dinner with my friend recently, and she was talking about how she'd been kind of beaten down by work. She's like, well, I used to be an optimistic person. And I thought of Laura, and I thought how she would never say that, because you choose optimism, and we should always choose to see things positively and expect the best. I work in wisdom normally, and I have mostly cross-pollination with Nick in Athena. But I work with Haley sometimes too, so involved across the clinic. For this project, I wanted to look at, compare demographics from the UCSF breast screening clinic surveys. We send out survey requests to everyone who comes in with a mammogram appointment. Now, many of these women respond to these surveys online before they arrive in the clinic, but for a period of time, we had a staff member in the clinic assisting patients who either didn't fill out or couldn't fill out at home these surveys. And I wanted to see what groups we were representing in these two related but separate cohorts, the group that was filling out the surveys in the clinic with staff assistants and the group that was filling out surveys at home ahead of time. So we collected data from 10,755 unique patients, and this data was collected from December 2012 to May 2018. Have about 7,869 responses that were collected online before visits, and 2,886 responses that were collected in the clinic with assistance. So in all of these graphs, blue represents those who filled out their surveys online before their visits, and the orange represents the group that filled out their surveys in the clinic with staff member assistance on tablets. And as you can see, the group which filled out their surveys online before their visits had a lower mean age, a lower mean weight, and a lower mean BMI. You can look at all the data below, but all of these relationships were statistically significant. Again, blue represents online before visits, and orange represents those who filled out their surveys in the clinic with staff assistance. The value got knocked out of that blue guy, but it's 79.93% of the group which filled out their surveys online beforehand were college educated or more, compared with 66.87% of the group which filled out their surveys in clinic with staff assistance. On the graph on the right, you can see, or on your right, that the group which submitted their surveys online before their visits also was more likely to be white. And both of these are statistically significant as well. Additionally, the group still in blue, which filled out their surveys online before visits, were less likely to be Black or African American, were less likely to be Hispanic, Latino, or Spanish, and were more likely to be married. Again, all of these relationships are statistically significant, and the wording on the Hispanic, Latino, or Spanish question is just, I think, how we phrase it in the surveys. So as a brief summary of what we just talked about, the group which fills out their surveys online before visits seems to represent traditionally more well-represented groups better. The group which fills out their surveys online before visits is more likely to be white, is more likely to be educated at the college level or beyond, is less likely to be Black or African American, is less likely to be Hispanic, Latino, or Spanish. They also have a lower mean weight, lower mean age, and lower mean BMI. Groups that are traditionally more well-represented are usually associated with better health outcomes. And you can say the same for groups with lower mean BMI, which is why these results were surprising. The group that filled out their surveys online before visits tended to report more instances of having 2 or more diagnosed comorbidities, and they also were more likely to report having poor or fair health over the last 30 days than the group which submitted their surveys in the clinic with staff assistants. I think that this is really surprising and interesting, and I'll talk a little bit more about why I think this might be the case later. Because we didn't have information in the screening clinic survey results about income, I wanted to take a look at some of the breast care center survey results to come up with sort of like a proxy for income without an explicit income question. I wanted to look at how Medi-Cal, Medicaid populations were represented in survey responses. Some disclaimers. Right now, I'm only working with data from fiscal year 2014. I have the fuller data set, but I didn't have time to analyze it for this presentation. And some of the trends that we saw in the screening clinic data are not reflected in the breast care center results from fiscal year 2014, although this could change when we look at the fuller data set. So looking at blue here represents the overall breast care center demographics, and in orange is the demographics of survey responders at the breast care center. So again, the value's gone, it's down there on the table, but overall, the breast care center population is about 13.6% covered by Medi-Cal, Medicaid, but the survey responders were only about 8.2% covered by Medi-Cal, Medicaid, which suggests that maybe income plays some kind of a role in who fills out surveys and the groups that we're representing. This, again, was statistically significant. So talking a little bit about conclusions and next steps and what this all means. It seems like groups that are traditionally more well-represented fulfill online survey requests at a higher rate. I also think that it might be interesting to add an income question to the Athena questionnaire so that we can learn a little bit more about our, the population that we're representing from like a socioeconomic standpoint. I also intend to compare what I found here more completely with the breast care center questionnaire data. In-clinic staff assistance, number 2, seems to help us acquire a more diverse representative sample of the population when it comes to surveys. And while, something that Laura mentioned is that the absolute difference in the percentages is not huge, but if you think about it this way, the group that filled out their surveys in the clinic with staff assistants represented the Black and African American population twice as well. It also represented the Hispanic, Latino, Spanish population about 25% better than online surveys alone. And I think that that is important, especially when we're looking forward to implications for online studies like Wisdom, which I'm involved with. The Healthy Heart Study, all of us, many of you in this room are involved in these studies, and studies are moving increasingly online for follow-up with patients and for surveillance. And I think that we need to make really intentional efforts to engage these populations and bring them to the table to ensure that they're represented in the science that's going to shape clinical care in the coming decades and years. Additionally, I also wanted to think back to that comorbidity slide, which showed that the group which filled out their surveys before visits at home tended to have, were more likely to have 2 or more diagnosed comorbidities, and they were also more likely to report having poor or fair health than the group which filled out their surveys in the clinic with staff assistants. There's a lot to dig into there. Part of, I don't have data about the healthcare access of these groups, but I think perhaps the group that represented traditionally more well-represented groups better, that was a little bit younger, that had a little bit lower mean BMI, might have more healthcare access and might have more opportunities to get diagnosed with comorbidities, to develop anxiety about those comorbidities, and perhaps their familiarity with online health surveys lets them answer these questions in a way that gives us this data. I'd love to do a little bit more work on that, and I honestly need to do some thinking about how we can investigate that using the questionnaires that we have in place now. But that's pretty much all I have. And any questions?
Great. So one issue that's been brought up to us, which is I think really important, is access to a computer, access to a smartphone. I think the small differences, rather than asking an income question, really is asking the question of what their access is and how do you provide that. And in fact, so much so, I can't remember who suggested it, Allison, but saying that we should be providing paper surveys or whatever because there's a group of people that just don't have access. And that was, I think at one point we thought about kiosks at grocery stores or kiosks at libraries. And so do you have any sense for whether any of this, and again, this is, where's the list? You can have something that is statistically significant, that is clinically insignificant. I think, those, yes, because you have thousands of patients, those numbers are statistically different. But I don't see a big difference in those groups. What is really driving the people who don't fill those surveys out? And maybe we should be asking questions to those people to say, did you not have time? And I think this has implications for one source. It has implications for, what we're expecting. If we're going to run our entire clinic on sending somebody a survey or sending something, how is that going to work? And I think there's an important lesson in here. I'm not sure what it is, but it is that, what happens to people who don't have access? What happens if someone can't send something back, if that isn't their primary mode? We're so used to being in an area where everyone's got a cell phone. How would you suggest we go about that? Do you think it's an access issue, or do you think it's just a characteristics?
It's tough to know a little bit, but I think access probably does play into it a little bit, at least. I think that, the group which filled out their surveys in the clinic with like an iPad or a staff member representing the African American population twice as well, while it is like a small absolute difference, I think, in mass, having better, more accurate representation is important. And I think that, maybe some of the things that were described when we were talking about this in terms of wisdom were like going to libraries and having, staff members sort of help people who don't have access, don't have familiarity using the internet or email, almost giving them a lesson in terms of completing the survey. But I think probably there are some access issues that are involved in these responses as well.
Yeah. It's interesting, we're just publishing a study, it's just going to press, showing that the iPad is basically the low literacy preferred option. So if you're administrating pen, pencil, or iPad, or on the computer, the iPad in the clinic is the low literacy best solution. People do fine with that. So I think the issue is not that people can't understand it or can't, that's not the difference. I think the issue is access, and I think that's going to be a huge issue for us if we want to run our clinic that way, and if we want to run our studies that way. That's coming up in Wisdom. It's come up in OneSource. So I think it's pretty critical for us to figure that out. So I think we should try and figure out how to do a focus group, just of the people that just pick 20 random people who filled things out online and didn't fill them out ahead of time.
Yeah.
And let's, try and figure that out. Who's taking on you're taking on this? Yeah. So let's try and work on that, because I think that's pretty important. Sabrina, okay. Yes, Laura.
So maybe those in the UCSF screening clinics, the 2,800 that have like staff assistants answering the questionnaires, that was actually on an iPad. And the reason why, one of the reasons, maybe the main reason why it was staff assisted, because we couldn't do it in the screening clinic itself. So these women had to be assisted to go to another room. Some of them actually had to be assisted to actually answer the questionnaire. You can actually ask Sarah Tyler, she was earlier here in the audience.
Yeah, Sarah.
Still there, because she did a lot of that work for many, many years, or for 2 years.
So Sarah, if the staff though had just handed them an iPad, if we bought the iPads and said if you haven't filled it out, letting people or do it right there, and we had it able to be organized online, would that have solved the problem?
Well, I think the initial issue was that there had to be a staff member there to put in, to activate the survey for that unique patient. So that was one of the main issues of actually needing that staff member. And then in terms of actually having most people just completed it on their own if I showed them, if I went through it with them the first 3 questions. And I had a lot of actually older patients who were like, oh, I need a lot of help with this, and then would grab it out of my hands after the first 5 questions. Be like, this is easy. So I think it's also about technology literacy and sort of reducing that anxiety for older patients. And then your specific question was exactly?
Well, so I think, again, I'm just trying to think about how to transition from it being a research study to have it being standard of practice. So one of the thing in one source, or everything we do, is saying this isn't research, this is our standard practice. So that means people at the front desk, this becomes their job. So that's why I've integrated the people who are running the clinics, Janet Black, our own clinic manager, Diana Bretzinger, to say, okay, this is your job. So part of when you check somebody in, they'll say people are overwhelmed. And Aheli, this gets to this whole issue of how are we using people? We're using people in all kinds of wasteful ways. So it's not that there isn't time to do this. There is time to do this if you stop doing wasteful things because you don't have the data. So if the person at the front desk basically had a really simple way to say, you haven't filled out your survey, click here, here's the pad, you just answer this here and there, and just like you would ask them what their social security issue is, and they could do it right there in the clinic. Would that have solved the problem?
So maybe
Wait,
one other comment.
let me just let Sarah answer that, and then you can go ahead.
I think there's 2 things. One is that the clinic staff doesn't want to take on more work.
No, I understand that, but let's assume that again we're going to take other work away, and we're going to give them this. Again, this is why you have to re-engineer the clinic process to change it, right? So if you did, then so let's just say that the clinic staff didn't have the option to say I won't do more work. Would that solve the problem?
I think it would. Yeah, I think part of the problem. One of the issues was activating the iPad for the patient.
Yeah.
And then the other issue was actually then printing out those results since they're not being integrated into the EMR.
So if we get it integrated into the EMR and we had a simple activation, those are the things that would solve the problem.
Emergency point number 1 on our list. But actually maybe what you may not know is that
I might not know.
one of the reasons, no, it's still not there, but it's number 1 on our list. So, but one of the reasons why we couldn't fix this in the screening clinic was because of the personnel at the front desk there. The woman who had been there for like 30 years, she retired last week.
Perfect.
And actually the current supervisor of all staff wants us to integrate, and she's actually behind this ticket to get this report integrated in the EMR. So we just need to get the right people together to make that happen.
In life, timing is everything.
And so the timing is now, and actually pretty quickly.
Yeah.
Well,
and
great.
That's great. So I think so that's important. But I still want to go and find out who are the people who are filling things out in the clinic. So we understand, did they have an access issue? Do they not have a smartphone? What places would work for them? So I think that's going to be critical. And as regards to being optimistic, Patrick, this is one of my father's favorite sayings: lead the expectant life. That means you just assume things are going to work out and you just go that direction. That's actually the best advice I ever got from my dad. Yeah. Patrick, you're on. Other Patrick.
All right. Good afternoon, everyone. So for My key takeaways during this intern year, I think would definitely have to be the importance and impact of patient advocacy, both in a clinical setting through my work, note-taking and question listing for the patient support corps, as well as on a more research level through coordinating the target trial, being able to educate patients on what the trial exactly is, and basically being able to increase their literacy regarding clinical trials and just their general health literacy as well. And as for how my work has been involved with other aspects of the UCSF Breast Care Center, I think the Target trial is a really great example of how it fits into this culture of high value, patient-centered care without really trying to overtreat the patient and just giving them the exact treatment that they need. And so with that, I'd like to segue into my presentation today about intraoperative radiation therapy, also known as IORT. So what exactly is IORT? It's basically an accelerated form of radiation therapy, and it's performed during the actual surgical procedure itself. So when you're receiving a partial mastectomy or a lumpectomy, you would receive the radiation after the tumor is excised using the radiation is performed using a machine like that pictured here. And so here are the general treatment steps involved with the process of IORT. Steps 1 through 3 are basically the steps for a partial mastectomy or a lumpectomy. And starting with step 4, after the tumor is excised, you insert the applicator head of the intrabeam device into the excavated tumor site, and then you deliver radiation for just 30 minutes to the tumor bed directly. And after that, the applicator is removed and the incision is closed like you would normally do. So why would one choose IORT over traditional radiation therapy? Well, one key benefit is reduced radiation exposure. So with IORT, you're receiving focused local radiation specifically to the tumor bed itself instead of having the entire breast irradiated like you would normally have with traditional radiation therapy. And this is beneficial in that you have a lot less potential radiation damage to the heart and lungs. And also with the IORT procedure, it uses soft X-rays, and so the radiation beam is rapidly attenuated as it passes through the breast tissue. So the highest dose of radiation is received by the exposed tissue in that excavated tumor site. And this radiation is rapidly attenuated as it moves further into the deeper breast tissue, so you don't have excess radiation damage. Another benefit of IORT is its cost effectiveness. So a 2013 study done by our very own Dr. Alvarado, as well as Dr. Esterman, found that single dose IORT as a radiation treatment is a lot more cost effective than regular radiation therapy. And it also provides a greater quality adjusted life year at a decreased cost. So what a quality adjusted life year is essentially a year of life taking into account the quality or the value of that year of life. So if you lived that year of life at perfect health, you would have a value of 1. If you were, for instance, bedridden in a hospital for most of that year, that value might drop to 0.5. So in addition to that 2013 study, there was also a 2017 study conducted by Vaida et al. In the UK, where they also looked at cost effectiveness of IORT. And they found similar results where IORT was, over a 10-year time frame, was significantly cheaper than regular radiation therapy, and it offered greater quality adjusted life years compared to regular radiation therapy as well. The third benefit of IORT is time, or time saved by the patient. So with regular radiation, a patient comes in on a daily basis, Monday through Friday, for usually an average of 5 weeks to receive radiation. And in the case that they have higher risk features in their cancer, they would need an additional 1.5 weeks of a radiation boost. However, with IORT, all of those 5 weeks of radiation is condensed into one 30-minute session. That's also really convenient because it's performed during the surgical procedure itself, so there's no need for further visits to the medical center. And in the event that a patient has higher risk features, that we can also offer them the additional 5 weeks of regular radiation therapy. And so in either case, if the patient has a low-risk cancer or a high-risk cancer, using IORT would save time because the IORT essentially replaces the boost treatment, the 1.5 weeks of boost treatment in the case of higher risk treatment. And so despite all of these benefits, there are some concerns regarding IORT. So while previous studies like the Target A and the Elliott trial have shown that IORT produces similar results for local control in early stage breast cancer patients, the IORT is still not considered the standard of care. The formal recommendation is that IORT only be conducted under, or only be delivered under a IRB approved protocol. And so that, in addition to limited long-term follow-up, has decreased the availability of IORT throughout the United States. And so with that, I'd like to segue into Target US, the trial that I've been coordinating for the past year. So Target US is a pragmatic registry trial for women with early stage breast cancer who will receive solely IORT as their radiation treatment. And so the goal or objectives of this study are to essentially develop an IRB approved protocol to continue offering IORT to patients that have been previously deemed to be at low risk for recurrence based on the previous Target A studies. So we enroll patients with similar eligibility criteria compared to that trial. And we also want to systematically collect and assess data for these patients so that we can further add to the knowledge pool for IORT. And so here are some of the eligibility, inclusion, and exclusion criteria. You can see in the inclusion criteria that most of these features are characteristic of low-risk cancers, whereas if you look at the exclusion criteria, you have factors like multifocal cancer, which are more indicative of higher risk tumors. So we want to really avoid enrolling higher risk patients while being able to offer lower risk patients the IORT. And so here's a general schema of what a patient goes through if they're enrolled in the trial. So once they're deemed eligible, they would receive partial mastectomy with IORT. And depending on what their pathologies data shows, if they have no high-risk features like lymphovascular invasion or factors like that, then they would receive no further local treatment. But if there are high-risk tumors, then we would follow that up with regular 5 weeks or so of radiation treatment, of the standard radiation treatment. And so here's a general status update of how Target has been going so far. So we have around 585 patients enrolled in the IORT only treatment arm with 120 in the IORT and regular radiation treatment arm for a total of around 705 patients so far. And Target itself is a multi-site trial, and here's just a list of all the trials participating, or all the sites participating in the trial. As you can see, we are pretty comprehensive and cover most of the country. And here is a general demographics analysis of the women in the trial. So majority of the patients enrolled are white patients, 9.4% Black, 3.7% Asian, and around 9.4% unknown. The average age of the patients enrolled ranged from 64 years to around 66 years old, with an average tumor size of around 12.5 to 15.5, so very small tumors. I should clarify, it's 12.5, 15.5 millimeters. And majority of the patients enrolled are postmenopausal as well. So regarding the follow-up status of these patients, so the red line indicates the median follow-up for these patients, and the bars represent how many patients are at each follow-up stage. So you can see that with the IORT treatment group, the majority, or the median follow-up is currently around 12 months or 1 year. For the IORT and EBRT treatment group, the median follow-up is around 1.5 years. And if we look at just all subjects in general, we're at a median follow-up of around 1 year. And unfortunately, with only 1 year median follow-up, we can't really conduct a great analysis of the local recurrence. And so the next steps of Target are to continue monitoring these patients throughout their follow-up protocol. And from this information, we can obtain a more updated recurrence data with longer median follow-up for a better validity of that data. And with longer follow-up, we can also acquire better disease-specific survival data over a period of, say, 5 years or 10 years or longer. And so in conclusion, I talked about many things today, but the key takeaways are that there are many benefits to IORT compared to regular radiation treatment. The 3 key benefits being reduced radiation exposure, cost effectiveness, and time saved on the patient's part. And many previous studies have shown that IORT produces similar local control results compared to regular radiation treatment. And the Target US is another trial that's aiming to show similar results, but it's currently ongoing, and we have a lower or shorter follow-up median, so we're going to continue following those patients out so that we can receive better data in the future. And so with that, I'd just like to thank Dr. Alvarado, Dr. Esserman, Sabrina, and all my fellow BCC interns for all their help and support throughout the past year. So thank you all.
Great job. So have you noticed sort of a trend for sort of a constant use across the sites, an increased use or a decreased use over the registry?
So based on my experience of looking over the data, it seems like there was a spike in accrual specifically at UCSF during last year, with more dwindling use this year. Across the other sites, I think it's fairly consistent. We recently introduced a change to the protocol where we increased the total accrual to 1,200 up from 750, but with that, we got rid of some reimbursement. So we had some sites that have stopped accruing due to that change, but we do currently still have around 10 sites or so that are still accruing despite the lack of compensation for follow-up data.
So, wondering whether, again, particularly if we want to test changing Key 67, at least short-term neoadjuvant, it's not truly neoadjuvant therapy, but short-term hormone exposure, making sure that that is not an exclusion criteria. Has that been changed?
Yes, that's been changed.
Yes. Yep. All right. Well, I think my last question for you is would you have expected with all of these potential benefits, why do you think everyone isn't moving to using IORT?
Yeah, that's a good question, and something that I've been thinking about as well. I think it's just sort of demonstrates the general tendency of clinicians or the medical field to stick to what they know instead of trying out more innovative techniques. And I think people are just wary of, I think specifically the local recurrence data, that potentially IORT might not be as effective in controlling local recurrence, but a lot of the data has shown that it's similarly effective with very minimal differences.
So you're saying people aren't necessarily very data-driven?
I guess I am.
But none of you will make that mistake, right? Okay, very good. Thank you very much, Patrick. All right, we're getting to the bitter end. Paul, come on up.
Okay. Hi, everyone. So my biggest takeaway for this first intern year was that we shouldn't be afraid of face the constructive criticism. What I meant by this is that in a positive way. So, I work in the imaging group, so I have many opportunities to work with both radiologists and surgeons. And in the beginning of my intern year, I recall that for the same result, they were giving like two opposite directions, and I was a little perplexed. But working with them for a long term, and by attending weekly tumor board, I found out it's natural to tackle the same problem with different perspective. from slightly different angle. So yeah, we shouldn't be afraid of that. And the collaborative opportunities. I think many studies want to use MR images, so I do have plenty large window for collaboration, and especially for iSpy 2.2, we're going to use MR images and biopsy for the surrogate endpoint. And I've done some of the work for iSpy 2, so that will be the collaboration opportunities. And okay, and also, I work physically away from other interns, not mentally, in this floor. So I found out, many interns do not know what my research is about, so hopefully today I can unveil it a little bit. So today my topic is background parenchymal enhancement, change on MRI in patients with this pre-surgical endocrine treatment of DCIS and its relations to recurrence. So this is outline of my presentation. I'll go over background and research questions, and then study design, results, and conclusions. So I'm gonna skip this slide because Emma already explained it pretty well, but basically we're looking at the same question. We want to stratify patients with DCIS, better. And again, I'm gonna skip this slide as well, but this is, so DCIS is not a single disease, and Dr. Esserman doesn't, and because of terminology carcinoma in DCIS, many people think DCIS is very serious disease and they tend to overtreat it. So Dr. Esserman, of course, is very against this, so she coined a new terminology, indolent lesional epithelium origin, IDLE. So hopefully we're gonna see this terminology change in the next few years. Okay, so which imaging modalities do we use to detect the breast cancer? So for screening stage, we do use mammography. And once there's a suspicious finding, then we move on to diagnostic mammography, which is more detailed mammography, or we use the ultrasound to tell the difference between the liquid cyst and the solid mass, or we use MRI, especially for dense breast patients. And my research is based on MRI, so let me explain a little bit about what MRI is. MRI, it basically provides you images of the organs and the soft tissue. And the way this works is that unlike other many imaging methods, it doesn't use X-ray radiation, but it does use magnet and the radio frequency wave. And our body is composed of 70% water, and water has 2 protons. And the magnet interact with the protons on the water molecule, and it provides us this image. And MRI can be taken with and without contrast, and if we use the contrast, which is typically gadolinium, we can get a clearer image. Okay, so why should we use MRI over mammography? Don't get me wrong, mammography is a great tool. However, it has limited sensitivity, which is ability to detect the true positive, and the low specificity, which is ability to detect the true negative. So, we use the contrast MRI to resolve this issue. And by doing so, we can detect nearly 100% of all invasive breast cancer, because the high vascularity in the cancer region shows high contrast image. American Cancer Society reflected on this, and for high-risk patients, they changed their guideline and recommended MRI screening. So what's the population for high-risk breast cancer patients? Basically, they do have either BRCA mutations, or they had the radiation on their younger age. And we tend to look at the breast density, to predict the breast cancer risk. However, turns out that it's not really good predictor for this high-risk population. So many research has done to find a new imaging biomarker, and that's the new imaging biomarker called BPE, which stands for background parenchymal enhancement, is introduced. So BP is basically enhancement of the normal breast tissue, and one may ask, what's the difference between the breast density and BPE? That's a very good question. Though not all the breast tissue enhanced, so it's pretty much the unique physiological response of the individual woman. And among high-risk patients, there's many study has shown that BP can be a good predictor for breast cancer. And in clinical setting, we have 4 different categories, which is minimal, mild, moderate, and marked. And you can clearly see enhancement through those categories. Okay, so research question is that can BPI stratify patients with DCIS? And also, can BPE monitor the response to the endocrine therapy? And also, is the change of BPE associated with the recurrence? And to answer these questions, we look at BP at baseline and the change of BPE and the presence of invasive cancer as surgery and recurrence. Okay, so this was the retrospective study, and we started from the spreadsheet that was initiated by Dr. Mukhtar, and that spreadsheet was mainly composed of patients from different imaging studies. And I do not want to go over every single detail here, but we set our inclusion criteria, and then we narrow it down to a total number of 24 patients, and among them there were 5 recurrence cases. And this is an overview of the patient timeline. So once they are diagnosed with the DCIS, we took the baseline MR, and then they went over the endocrine therapy for a short term. And in the middle of the endocrine therapy, or at the end of the endocrine therapy, they took the second MR. And then they went to surgery, and we look at if the surgery path was invasive or not, and we also check the recurrence. Okay, the change of BP was interpreted by 2 different radiologists, and we used the RadCap to capture the data, and there were 6 different categories, which are significantly decreased, decreased, no change, increased, significantly increased, or uninterpretable. Okay, so here's the result. First off, a caveat is that unfortunately this figure is not up to date, so numbers might be slightly off, but trend is the same. So, and Dr. Yao thankfully generated this plot for us. So this curve is called Kaplan-Meier curve. This shows the recurrence-free survival over time. So y-axis is recurrence-free survival, and x-axis is a month. And basically, if the line drops from the top, that's the bad signal. So here, the blue and the gray line means bad signal. So in this Kaplan-Meier curve, we simplify the categories into 4 different categories, which are decreased, no change, increased, or uninterpretable BPE. And we found 2 counterintuitive results here. So our hypothesis is that if BP decreased, that's the good signal. However, all 5 recurrences were found on the decreased BP category or uninterpretable. And in addition to that, there were 5 invasive cancers found on the surgery, and we thought, they may have aggressive DCIS, so their prognosis wouldn't be good. However, they all belong to the no recurrence group. A chance is that they got more aggressive treatment after the surgery, so that resolved the issue. And one of the confounding factor was that this study included many old images, so it was unilateral. So typically we look at BP on the contralateral or unaffected breast. However, we had to look at ipsilateral or affected breast for this study. So sometimes DCIS was indiscernible from the BPE, so that's a confounding factor here. Okay, in conclusion, the clinical relevance of this study is that substantial decrease of BPE in response to endocrine therapy may identify patients with high likelihood of recurrence. And the future direction is that in this study, we only look at BPE, but in addition to that, we can also look at suspicious lesion and add that on to independent variable and see its correlation with different outcomes like recurrence. And also, I told you already, but for the future patients, we can assess BP on the contralateral or unaffected breast side. And the sample size was only 24, so it wasn't it was difficult to draw any significant conclusions. So we should increase the sample size. And last but not least, we also do a lot of research on the quantitative BPE, which is computer assessed measurement. And we can add machine learning algorithm for that. Okay, thank you so much for everyone listed here and for my internship class for your friendship. Thank you.
So Paul, I'm going to ask you my usual question about context. So Michael first.
So the ones that had the recurrence, I mean, could it be that they had a very large area and then the surgeon was overconfident in taking a small effectiveness? I mean, it could be.
No, I think, I honestly, what I think it's taking the BPE out of context doesn't make sense. So one of the things you see is if everything kind of goes away and the lesion persists, those are the people that wind up going to surgery, because this is part of our active surveillance cohort too. And so, if everything looked good, we just left them alone. So the people who wind up going to the OR wind up having something is like the BPE went away, but the DCI has persisted. So you can see whether you think it, right? So that's somehow not captured. I think the study needs to be done looking at BPE on the affected side, and that you want to look at, what I find really interesting is about how often is it possible for the radiologist to tell where the DCIS is if they aren't told where the biopsy was? How often? Right. How often is that?
I don't have exact statistics, but I can say many times they're confused, between DCIS and BP.
Yeah, so about half. I mean, half the time it's probably just a risk factor, right? So you just can't tell the difference. I mean, if you didn't tell a radiologist where it was. So there's sometimes you just see diffuse background enhancement. Sometimes there's something focal, which, then we can tell the difference. And over time, what happens is some of that stuff goes away. And if the DCIS persists, then you want to maybe operate on them or do something about it. Yeah.
I think it would also be interesting to see if maybe the change in BPE is a reflection of endocrine therapy sensitivity. So maybe people who need endocrine therapy to prevent recurrence will have a drop.
Well, I think what you're seeing is endocrine sensitivity of the parenchyma, but not endocrine sensitivity of the lesion. Right. So what I think that this looks like an anomalous finding, but I think probably what that reflects is the background's going away and you get this persistent lesion, and only those people with persistent lesions are the ones who actually have something that's of importance. And I think there's something else really interesting that I realized is that sometimes on imaging things don't necessarily, like on standard imaging, like ultrasound or mammogram in these ultra low risk situations, nothing looked like it changed on mammogram or ultrasound, and when I took people to the OR, it had all kind of just gone away. So I felt stupid for operating on them. Anyway, especially since someone had a complication. But I think that a lot of this stuff is more complicated than it looks. So it's time for you and Rita and I to have like another fun Saturday afternoon to go through all the data. Because you didn't show any of the data stratified by the variables that Rita and I went over with you last spring, right? Are you working on that?
Yes.
Okay, great. Well, why don't you work on compiling that, and then we'll have another session. Zilos?
Yes, so I think the most important thing that I learned this year was this this idea of collaboration. And I noticed my name was name dropped a couple times already within today, and it's like I had my projects that I worked on, and then I somehow ended up working on a lot of like Dr. Mukhtar stuff too. I ended up doing like a small little project with the PSC with the survey data, and then like my fellow interns would like ask me for some help sometimes, and I felt and originally, like when I came into this program, I was kind of like that odd duckling that wasn't pre-med. I was like, do I really truly have a place here? And I think over the year I kind of learned, yes I do. And so with that, I'm gonna get started. So little background, I think Kel covered it already. I'm studying the molecular subtypes of invasive lobular carcinoma. So ILC is defined by its non-cohesive diffuse growth pattern, and this is primarily from the lack of E-cadherin present in the tumor. So previous studies, in 2015, the TCGA group developed a 60-gene classifier that broke down ILC patients into 3 subtypes: reactive-like, immune-related, and proliferative. And then they kind of reported some findings where if you're in a particular subtype, you're more likely to express certain genes, higher expression or lower expression, and what have you. And this was like the heat map of those 60 genes that came out of their patients. You could clearly see 3 different groups. So my project that I worked on was more or less taking this classifier that they developed and applying it to the I-SPY patients. Just kind of quick reminder again what the I-SPY 2 trial is. A lot of my coworkers have already covered it today, but I guess a small thing that's a little different about my project was that we included the low-risk registry. So I-SPY is usually for the high-risk cases, usually stage 2, 3 cancer. We included the patients that were excluded from the I-SPY trial, but a lot of patients usually opt in to go into the low-risk registry. So I pulled the lobular cases out of the low-risk registry as well to end up with a nice 131 ILC mixed IDC ILC tumors. 80% of the patients came from the I-SPY 2 trial, 51 came from the low-risk registry, and to conduct all these analyses, it was necessary that everyone had their expression arrays done, and we used the Agilent microarrays. So the analysis plan is to use their 60-gene classifier, and their classifier uses a technique called near-centroid, and I'll quickly explain what that is. So imagine, this is kind of like a 2D example. So they established centroids, and that's like, imagine like the center of the red region, the center of the green region, the center of the blue region. This XJ, as you could call it, you're wondering, which one does it really go to? And eventually, whatever comes out to be like the smallest distance, we use Euclidean distance. That's what it would be classified to. Kind of, if you want to scale this on like a 3D example, you could take these 3 exit signs that we have in this room. Dr. Mukhtar would clearly be at that centroid. Dr. Esrin would probably be here, and Patrick would probably be at this one. But like cases like maybe like Andre, you're like, it's kind of hard to tell which centroid you truly belong to. And I think it'll be important for you to keep that at the back of your mind. So here are some of the results from the classification that we use. So on the left is the entire cohort. We did lean towards the higher risk side. It was split 50-50, about 50-50, pure ILC and mixed ILC IDC. And since we are working with the ILC population, most of them tend to be the hormone positive HER2 negative group. PCR rate was 16%, which actually matches the 16% rate of hormone positive HER2 negative cases in I-SPY. And then on the right side, you can see the breakdown based off of the 3 subtypes. So I took their classifier, classified it on R131, and this is our breakdown. It does seem within the I-SPY 2 ones, they do lean towards proliferative, which isn't too surprising considering they are of the high-risk cases. Another important notice is the triple negatives tend to be part of this reactive like group. And then you can see the differences in the risk categories as well, MP high 1, high 2, and then the low risk registry. So kind of like the takeaways is that we do have that higher risk population, and you saw that there. The triple negative patients is kind of alarming as well. And then the PCR rates weren't statistically significant. And then kind of as like, here are the results that we have. And then it was kind of like important to kind of remember like the purpose and like the background of this project is that our patient cohort is like inherently different from like the one studied by the TCGA. So we had a lot of I-SPY patients, which made us lean towards the high-risk patients. We did use a different expression array type, microarray versus RNA-seq. That's important to consider. And then that these near-centroid techniques require like a lot of baseline assumptions. And so moving back to like, remember when all the genes that I said were supposedly significantly different that stratified the subtypes for the TCGA, I checked to see whether or not those genes would actually be significant for our cohort as well. And then plot it all out, and you're wondering, wait, why are only 2 of the genes that they said would be significant actually coming out significant? And if you remember this concept of the near centroid, where's the laser pointer? Okay, so I plotted the distance to each of the centroids that they used for our patients. So everyone in red was classified as the reactive-like, everyone in green was classified as the immune-related, and everyone in blue was classified as the proliferative according to their classifier. So the ideal like plot of this, you would see like, oh, the reactive-like have the lowest distance to the reactive-like centroid. And then so you would think it'd go low, kind of dying here, low, high, high. And then on the next plot, it looks exactly as you would expect. It goes high, low, high. And then the one that's kind of like alarming is this proliferative centroid group, where it seems to be a lot of the cases are just as close to the proliferative centroid. So a lot of these cases could have easily went into the other 2 centroids. And that it's kind of alarming in the sense that maybe our data wasn't necessarily fit for the TCGA classifier to begin with. So we started kind of like moving back a little more, and so in an exploratory analysis, we used something else called consensus clustering on the most varying genes of these I-SPY cases to kind of like generate new clusterings to see if that we can check to kind of like quality control our data. And so to explain what consensus clustering really is, I kind of came up with this yesterday for the fact that it's a little difficult to understand. But imagine we have like a bunch of fruit, right? And let's just take, you have no knowledge of what fruit is. Like you've never eaten an apple, never eaten an orange, never eaten a banana. And you take a sample of them and you randomly grab 2 fruit. And you're like, here's an apple and here's another apple. And you're like, yes, these are the same object. So that's like a successful pairing. And then you kind of like grab another 2 things and you have 2 oranges. You're like, yes, these are still like, they agree, it's 2 oranges. And now imagine if you had some of these unripened fruit and you grabbed a green apple and like a really green banana and you're like, wait, it might be? And so like that, it creates like this pairing consensus clustering system. So basically using that, we had a label for the 131 patients again, and we like plotted it against the original TCGA classified subtypings, and we had a really low concordance rate. And I think that just and so with that, we just kind of like followed further in with the TCGA protocol that they used in 2015. And so we created a classifier of our very own, and then within our 1,000 differentially expressed genes, only 22 of the genes from the original 60 gene classifier were even part of our 1,000. And then when we compare our 60 gene classifier and their 60 gene classifier, there was a really small overlap of 7 genes. And then kind of like wrap it up there is like the low concordance rate and the whole quality control checking system of our data kind of shows that there are inherent underlying differences between our patients and the TCGA patients that they used. Things that may like spark interest is the fact that we had a much higher risk cohort, and then that our findings do suggest that there exists a fair amount of like molecular heterogeneity among ILC, and I think it's worthwhile to study more of these genes that do cause this differential expression moving forward. That's about it. I'd like to thank pretty much everyone in this room, my fellow interns, Dr. Esserman, Dr. Yao, Dr. Mokhtar, Laura V for helping with advising on the abstract that's due later today, and yeah.
So, Zelos, it's really interesting that there are a lot of people who think that there's a lot of lobulars that are kind of, maybe even idle cancers, and so there's this big heterogeneous, there's a lot of heterogeneity in sort of what is a lobular cancer. So maybe it's not helpful, so there's two possible questions, right? One is, maybe is it that there isn't necessarily something that's really unique about being lobular, or is it, and that you can have within, or is it that within any kind of cancer, whether it's ductal or lobular, you can have a range from super low risk, ultra low risk, to very high risk, and they can exist separately. So I guess if you were thinking about how to help with classification, would it be your idea that we should just get rid of the lobular altogether and sort of look at low risk versus high risk? Or should we say, well, you can have ductal and lobular, there probably are differences between them, but within it there's like a range of heterogeneity. Right, so there are, okay, and thinking about your concordance example, the green fruit, so the green, is Christine in here? So maybe one of the things, the first thing we want to do is sort of find out what, if we had a classifier for ultra low risk, that we could take those out of the equation. So the most common thing is what's ultra low risk. Get rid of those, then ask what's different about lobular. Or are we just better off saying what's low versus high risk, and maybe there isn't a difference on lobular? What's your thought?
I follow under your hypothesis that there is a spectrum of low to high risk on all of these seemingly independent diseases of their own. IDC clearly has a low to high risk spectrum. DCIS, as we have discovered, has a low to high risk. I also believe ILC has that like low to high risk spectrum. And I think the really weird case, and it kind of like became more of an alarming thing in my project, was the mixed ILC IDC cases. And it's weird because like I don't know how often you would actually catch that, like histologically. Like how many people of IDC, like what if you took like the wrong biopsy of the wrong region? Like did you miss the fact that they might have been mixed? So I think that in and of itself is pretty interesting and is well worth like kind of like processing and like food for thought type of deal. But yeah.
It is. Rita, any comment from you?
No, Zelos, awesome job.
That's right. I want to thank everybody, especially, we finished relatively on time, which is really a small miracle in and of itself. I especially want to thank Sabrina for being an awesome chaperone for the interns all year long, advisor, and for doing such a great job of managing the whole selection process and getting everybody trained and educated. So big hand of applause to Sabrina. Sabrina, mark on your calendar, you're coming back for the intern reunion. So once part of the vortex, always part of the vortex. All of you interns this year will have to learn that later. But this has been just a fabulous morning, and I think it gives you a sense of the breadth of the work that's going on, but really how integral the interns are and how they actually seed on everyone working together helps really seed and push the agenda forward for how common tools, common approaches, whether you're looking at trying to integrate quality of life into efficacy and personal preference, or whether you're really trying to understand how to do a better job of looking at biology from one spectrum, from low risk to high risk, and how to use some of the imaging tools, and really how to try and make sure that what we're doing is thinking about value to patients and coming up with better solutions. So huge round of applause to all the interns. Hope Timberlake is usually here, but she did an amazing job as well at advising you, right? Everyone enjoyed that, so the big round of applause to Hope and Absentia. And then just welcome to the new interns. You have big shoes to fill. I have no doubt that you will do it. So go out and get to work. No. Thanks, everybody.